Hi guys. Welcome back. Yes, we are live again, and in this session we'll be revising all the CVS. Right. तो ये बहुत ही लेंदी सेशन भी हो सकता है, as we will be revising all of it. एंड लास्ट क्लास में एंटी हाइपरटेंसिव में GNC8 की गाइडलाइंस वाली स्लाइड रह गई थी, सो टुडे वी विल बी मतलब इस सेशन में हम वो भी लेंगे. So hi guys, what's up? Welcome back. I am Shiv Virmani, Indian medical student and author of the book Unacademy. Welcome Zahir, welcome Prakhar, welcome. So first of all, we will be starting RAS. So renin, angiotensin, aldosterone system. So guys, renin is a substance that is secreted by the JG cells of the kidney, juxtaglomerular cells of the kidney. And what is the stimulus? How this renin is produced? So guys, if there is a NaCl loss, if there is a deficiency of Na, basically सोडियम की डेफिशिएंसी होगी तो fall in BP, fall in blood volume, renal ischemia. So these are the stimulus or pre-deciding factors that will be increasing the release of renin from the JG cells. And this you all know that renin converts the angiotensinogen to angiotensin 1. So angiotensin 1 gets converted to angiotensin 2 by the help of ACE, and then 2 converts to 3, 3 converts to angiotensin 4, and 4 gets converted to ultimately inactive fragments, right? So what is important here? So important is angiotensin 2, that is the 8 peptide compound or octapeptide compound, and this is the main thing, this is the main substance जो कि जिसका एक्शन क्या आता है, it can do vasoconstrictions, it can retain the sodium and water, plus aldosterone secretions, plus it will be increasing the aldosterone secretion, right? So angiotensin 2 and angiotensin 3, these two compounds, they increase the aldosterone secretion, and further aldosterone, what aldosterone will do, it will rise in BP and it will be increasing the blood volume by retention of sodium and water, plus ये remodeling करेगा and permanent cardiac death, right? So somewhere renin is also good, but अगर बॉडी के अंदर पैथोलॉजीज हैं देन रेनिन को हमें ब्लॉक करना है, राइट? सो फर्स्ट ड्रग जो हम दे सकते हैं, चलो वो हम आगे डिस्कस करेंगे पूरा मैकेनिज्म. सो बेसिकली टिश्यू लोकल रेनिन एंजियोटेंसिन सिस्टम, देयर आर ऑफ टू टाइप्स, एक्सट्रिंसिक एंड इंट्रिंसिक. Extrinsic local RAS and intrinsic local RAS. So extrinsic, as the name suggests, blood vessels capture the angiotensinogen and the renin and they convert it to the angiotensin 1, and then angiotensin 1 is converted to the 2, and then it is released by the intima of the blood vessel. So it is a locally produced and it is locally acted, right? But what happens in intrinsic, basically few organs only is having the capacity to run intrinsic local RAS. So heart, brain, blood vessel, kidney, adrenals, they possess the capacity to produce all components of the RAS. So they generate the angiotensin 2, 3 intracellularly. But in this, it was not produced intracellularly. Right. This was extracellularly. Right. So they causes cell growth, cell death, remodeling and apoptosis. Right. So how renin is formed? Renin is synthesized in the JG cells or juxtaglomerular cells of the kidney and in other tissues, right, as pre-prorenin. So pre-prorenin is a larger peptide. It is same as insulin, pre-proinsulin, and pre-proinsulin is also a larger peptide. So when there is appropriate stimuli like Na deficiency, blood BP low jana, or decrease in the blood volume, so pre-prorenin, the larger peptide that is pre-prorenin, will get converted to the prorenin, and then prorenin will be converted to the renin, right? And prorenin is activated by both enzymatically and non-enzymatically. So what it means is enzymatic activation is irreversible and non-enzymatic activation is reversible. So enzymatic activation, that is irreversible, there is pro-convertase or cathepsin that cleaves off the prorenin to renin when there is a stimulus, right? But non-enzymatic activation is when it basically it binds to the PRR, prorenin receptor, and transmembrane, it is a transmembrane protein. So PRR is a receptor for prorenin, for pre-prorenin. So pre-prorenin gets bind to a transmembrane receptor, that is prorenin receptor. So from here, prorenin, the pre-prorenin that is present in the heart, blood vessel, brain and other tissues, वो उसका conformational change आएगा and it will be converted to the prorenin. Right, so what is happening here? Pre-prorenin is getting converted to the prorenin by attaching to the transmembrane protein, and it is due to a non-enzymatic activation. So thus we are referring it as non-enzymatic activation because it is not utilizing any enzyme. But here enzymatic activation needs an enzyme, that is pro-convertase and cathepsin. These are the enzyme that cleaves the pre-prorenin to renin. But here none of the enzyme is utilized, only the binding is there, and thus the pre-prorenin is converted to the prorenin. Right, and now non-enzymatic activation possess the effects of the prorenin. Angiotensin, so basically it is up to two types of effects can be produced: angiotensin 2 dependent and angiotensin 2 independent. So generally effects are same, but the mechanism is different, right? So when there is a angiotensin 2 dependent, so renin is there, renin will be converting the angiotensinogen to 1, then angiotensin 1 will be converting to the angiotensin 2 with the help of ACE. Then angiotensin 2 will be going to the AT receptors and thus it will be activating the MAP kinase. प्लाज्मोजेनिक एक्टिवेशन का जो है उसका इनिबिशन हो जाएगा. जे के स्टार्ट pathways will be enhanced, transcription factors, proton cogenes, and thus what it will be doing, it will be inhibiting the cell growth, it will be doing the apoptosis, it will be doing the fibrosis, it will be remodeling the myocardial tissue जहाँ पर initially damage हुआ है. then nephropathy भी हो सकती है, retinopathy भी हो सकती है. And now let's discuss the angiotensin 2 independent. So this is the prorenin that will be binding to the receptor, prorenin receptor, and इसकी intracellular signaling की वजह से it is an intracellular mechanism and non-enzymatic mechanism, but effect same आएगा, same effects will be produced, right? So action of the angiotensin 2 on CVS, the most prominent action is vasoconstriction. So angiotensin 2 produces vasoconstriction. So no tachyphylaxis is seen, no immediate tolerance. Tachyphylaxis का मतलब immediate tolerance is not there. Then there is rise in BP, right? and increase in the force of myocardial contraction, but do not activate SA node or AV node. So it is less arrhythmogenic or no arrhythmogenic activity is produced, right? Because it cannot activate SA node or it cannot influence the SA or AV node, right? But on chronic therapy, myocardial hypertrophy, hyperplasia and increased cellular matrix can be seen. देखो एंजियोटेंसिन 2 की वजह से देयर कैन बी रीमॉडलिंग वाले चेंजेस, दैट इज हाइपरट्रोफी, हाइपरप्लेजिया एंड इंट्रासेलुलर मैट्रिक्स विल बी इंक्रीज्ड. लॉन्ग स्टैंडिंग हाइपरटेंशन increases the vessel wall as well as the intimal thickness plus causes the ventricular hypertrophy. So long standing hypertension increases the vessel wall as well as intimal thickness plus causes the ventricular hypertrophy. So there is fibrosis, dilation of the infarcted area with hypertrophy of the non-infarcted area after MI. So basically there will be, when there is an infarct or there is a ischemia, there will be fibrosis, dilation, hypertrophy, right? So जो भी एरिया infarct हो चुका है उसमें as such change नहीं आएगा, वो टिश्यू डैमेज हो जाएगा और उसका फाइब्रोसिस हो जाएगा परमानेंट एंड डायलेट हो जाएगा. बट जस्ट टू कॉम्पेंसेट द फंक्शंस, तो जो उसके पास वाला एरिया है वो देखो, लेट्स इमेजिन दिस इज द नॉर्मल कार्डियक टिश्यू, बट इतने एरिया पर क्या हो गया, इस्कीमिया हो गया, ब्लड सप्लाई बंद हो गई, ठीक है. सो ये वाला एरिया तो अब क्या हो जाएगा, ये वाला एरिया हो जाएगा डायलेट. सो ये वाला एरिया जो है ये पतला हो जाएगा, फाइब्रोसिस हो जाएगा और डायलेट हो जाएगा, राइट. बट अब इसका फंक्शन तो बंद हो गया ना, ये फंक्शन नहीं कर पाएगा, राइट, प्रॉपरली कॉन्ट्रैक्ट नहीं कर पाएगा या रिलैक्स भी नहीं कर पाएगा. सो जस्ट टू कॉम्पेंसेट द फंक्शंस, ये वाला एरिया जो है ये बढ़ जाएगा, इसकी हाइपरट्रोफी हो जाएगी. तो अब ये पहले अगर इतना था तो ये डबल हो गया. सो 10 ये इसका फंक्शन बढ़ जाएगा और इसकी हाइपरट्रोफी हो जाएगी, राइट. एंड एड्रीनल कॉर्टेक्स के ऊपर एंजियोटेंसिन 2 का क्या फंक्शन आता है, इट रिलीजेस द एल्डोस्टेरॉन एंड इट एक्ट्स ऑन DCT एंड इट प्रमोट्स द रीअब्जॉर्प्शन ऑफ Na+, राइट. एंड Na+ तो रीअब्जॉर्ब होता है बट K+ और H+ एक्सक्रीट आउट होते हैं, ये रीअब्जॉर्ब नहीं होते, ये यूरिन से बाहर निकल जाते हैं. बट यूरिन से रीअब्जॉर्ब क्या हो जाता है, Na+ गेट्स रीअब्जॉर्ब्ड. किडनी की मैं बात करूं तो बाइकार्बोनेट आयंस, सोडियम क्लोराइड का रीअब्जॉर्प्शन होता है. एंड इंक्रीज GFR बाय कंस्ट्रिक्टिंग द ग्लोमेरुलर इफरेंट वेसल. सो कुछ ऐसा होता है, दिस इज द एफरेंट वेसल एंड दिस इज द इफरेंट वेसल. एफरेंट वेसल वो होती है जहाँ से ब्लड आता है, इफरेंट वेसल वो होती है जहाँ से ब्लड जाता है, राइट. सो दिस इज द ग्लोमेरुलस, दिस इज बोमेंस कैप्सूल, राइट. सो जहाँ से ब्लड आ रहा है वो एरिया डायलेटेड है, प्लस जहाँ से ब्लड निकल रहा है, जा रहा है, वहाँ कंस्ट्रिक्ट हो चुका है. सो एज पर कॉमन सेंस अगर ये यहाँ से ब्लड ज़्यादा अमाउंट में आ रहा है और बाहर नहीं जा पा रहा तो GFR विल बी इंक्रीज्ड, राइट. दस GFR इंक्रीज हो जाएगी. CNS पर एंजियोटेंसिन 2 का इफेक्ट क्या आता है, इट इंक्रीजेस द सिंपैथेटिक आउटफ्लो, बट बहुत ही कम चांसेस होते हैं या बहुत हाई क्वांटिटी में हो तो ही CNS को इफेक्ट करता है, एज सच ज़्यादा इफेक्ट नहीं करता. सो ऑन CNS it increases the central sympathetic outflow and gain access to the periventricular areas of the brain that induce drinking behavior, right. Plus peripheral sympathetic structure में it enhances the sympathetic activity, it increases the adrenaline from the adrenal medulla, right. एल्डोस्टेरॉन भी तो एड्रीनल्स को बहुत ज़्यादा इफेक्ट करता है, बिकॉज कॉर्टेक्स को स्टिमुलेट करता है तो एल्डोस्टेरॉन निकलता है, और मेड्यूला को स्टिमुलेट करता है तो एड्रेनलिन निकलता है, राइट, एल्डोस्टेरॉन. बट इनिशियली राइज होता है एल्डोस्टेरॉन का और एड्रेनलिन के लिए ज़्यादा क्वांटिटी चाहिए होती है. व्हाट इज द मैकेनिज्म, अगर हम इसकी मैकेनिज्म की बात करें तो देयर आर β1 रिसेप्टर्स दैट आर प्रेजेंट ऑन JG cells. So there are β1 receptors that are present on JG cells एंड जेजी सेल्स पर स्टिमुलस आया जिसने बीटा 1 रिसेप्टर्स को एक्टिवेट कर दिया। बीटा 1 रिसेप्टर्स को एक्टिवेट करने के बाद क्या हुआ, रेनिन सिक्रीट हुआ, राइट। जो प्रो रेनिन था इट गेट्स कन्वर्टेड टू रेनिन। रेनिन आया, रेनिन ने एंजियोटेंसिनोजेन को एंजियोटेंसिन 1 में कन्वर्ट करा। एंजियोटेंसिन 1 ने एस की हेल्प से एंजियोटेंसिन 2 में कन्वर्ट हुआ। Angiotensin 2 will be acting on the AT1 receptors and AT1 receptor will be increasing the adrenaline, the noradrenaline, plus they will be possessing a vasoconstrictory action, plus they will be increasing the aldosterone release. Then aldosterone is there that basically can do remodeling like left ventricular hypertrophy and other effects like that, and thus it can cause permanent cardiac death. Plus aldosterone और ये सब मैकेनिज्म जाकर अल्टीमेटली दे रिटेन द Na plus and H2O plus there is a excretion of K plus and H plus, right? So सबसे पहले अगर मैं बात करूं कि अगर हमें ये मैकेनिज्म स्टॉप करना है तो क्यों करना है स्टॉप, बिकॉज वी डोंट वांट दिस वाटर रिटेंशन। वन reason can be that we don't want this thing remodeling, right? हमें remodeling नहीं करनी, right? So हमें ये मैकेनिज्म ब्लॉक करना पड़ेगा। प्लस हमें वेसो कंस्ट्रिक्शन नहीं करना तो ये मैकेनिज्म ब्लॉक करना पड़ेगा, राइट। सो देयर आर 3 थिंग्स। सबसे पहले हमें वेसो कंस्ट्रिक्शन नहीं करना। वेसो कंस्ट्रिक्शन हो रही है तो हाइपरटेंशन वाले सिम्टम्स आ रहे हैं और एड्रेनलिन नॉर्मली रिलीज हो रहा है तो हाइपरटेंशन हो रही है, हमें नहीं करना है, सो वी विल बी ब्लॉकिंग इट। सो दैट्स वाई हमें जो ड्रग्स देनी है तो वो हम अभी डिस्कस करते हैं। तो रीज़न हमें ये ड्रग्स क्यों इम्पॉर्टेंट है वो ये है कि सबसे पहले हमें वेसो कंस्ट्रिक्शन नहीं करनी, दूसरा हमें रीमॉडलिंग को ब्लॉक करना है, तीसरा हमें अननेसेसरी सोडियम वाटर को रिटेन नहीं करना, राइट। दैट्स वाई वी विल बी गिविंग द रास इनहिबिटर्स, राइट। और अगर आपके कुछ डाउट्स हो तो आप मुझे पूछ सकते हो। सो नाउ कम्स द ड्रग्स। फर्स्ट ऑफ ऑल हम क्या कर सकते हैं, हम बीटा 1 को ब्लॉक कर सकते हैं सीधा। सो वी कैन ब्लॉक द बीटा 1 ताकि इसका स्टिमुलेशन ही ना हो, रेनिन रिलीज ही ना हो, तो हम यहाँ पर ब्लॉक कर देंगे यहीं पर सिंपैथेटिक ब्लॉकर्स और रेनिन रिलीज इनहिबिटर्स। रेनिन रिलीज इनहिबिटर्स, आई एम नॉट टॉकिंग अबाउट डायरेक्ट रेनिन इनहिबिटर्स, आई एम टॉकिंग अबाउट रेनिन रिलीज इनहिबिटर्स, दैट इज बीटा ब्लॉकर, ठीक है। सेकेंड थिंग हम क्या ब्लॉक कर सकते हैं, हम एलिस्केरन देकर डायरेक्ट रेनिन को इनहिबिट कर सकते हैं, डायरेक्ट हम रेनिन को इनहिबिट कर सकते हैं, राइट। एंड द ड्रग इज एलिस्केरन, राइट। देन व्हाट वी कैन डू इज वी कैन ब्लॉक दिस मैकेनिज्म बाय ब्लॉकिंग एस। सो हम एस को इनहिबिट कर सकते हैं ताकि एंजियोटेंसिन 1 तो बन गया, बट अब एज सच कोई भी यहाँ पर इफेक्ट नहीं हो रहा, राइट। सो हम इसको यहाँ ब्लॉक कर सकते हैं, एंजियोटेंसिन 1 को ब्लॉक कर सकते हैं ताकि एंजियोटेंसिन 2 में कन्वर्ट ना हो, ठीक है। बट इस मैकेनिज्म को अगर हमने ब्लॉक करा तो वील बी एक्यूमुलेटिंग अननेसेसरी ब्रेडिकाइनिन जिसके साइड इफेक्ट्स आते हैं। सो क्या होता है यहाँ पर, एंजियोटेंसिन 1 जब एंजियोटेंसिन 2 में कन्वर्ट होता है तो ब्रेडिकाइनिन भी मेटाबोलाइज होता है, राइट। अगर एंजियोटेंसिन 1 इज नॉट कन्वर्टिंग टू द एंजियोटेंसिन 2 सो ब्रेडिकाइनिन भी एक्यूमुलेट हो जाएगा, राइट। देन एंजियोटेंसिन 2 अगर हम बात करें तो एंजियोटेंसिन 2 विल बी एक्टिंग ऑन द AT1 रिसेप्टर्स, सो हम AT1 रिसेप्टर्स को ब्लॉक कर सकते हैं, राइट। ARBs एंजियोटेंसिन रिसेप्टर ब्लॉकर्स दे सकते हैं लाइक सार्टन वाली ड्रग्स, राइट। तो ये सब ब्लॉक हो जाएगा, राइट। प्लस फिर हम क्या दे सकते हैं, हम दे सकते हैं एल्डोस्टेरॉन को के ब्लॉकर्स, ताकि फिर हम ये सब ब्लॉक कर पाए। सो एल्डोस्टेरॉन ब्लॉकर्स जो है वो रिटेंशन नहीं होने देंगे प्लस रीमॉडलिंग नहीं होने देंगे, बट वेसोकंस्ट्रिक्शन और ये सब होएगा, राइट। सो वी आर हैविंग दिस 5 टाइप्स ऑफ रास इनहिबिटर्स, राइट, जो कि हम दे सकते हैं। सो गाइज एस इनहिबिटर्स की बात करते हैं। एस इनहिबिटर्स आर द ड्रग्स जो कि एंजियोटेंसिन 1 को एंजियोटेंसिन 2 में कन्वर्ट नहीं होने देते, बट इसका एक साइड इफेक्ट है कि ब्रेडिकाइनिन इज एक्यूमुलेटेड, बिकॉज ये मैकेनिज्म अगर ब्लॉक हो जाएगा तो ब्रेडिकाइनिन का मेटाबॉलिज्म भी ब्लॉक हो जाएगा। एंड द ड्रग्स वी आर हैविंग इज प्रिल वाली ड्रग्स, प्रिल, कैप्टोप्रिल, लिसिनोप्रिल, एनालाप्रिल, रैमीप्रिल, perindopril, moxapril, right? All are the prodrugs except captopril and lisinopril. These are active drugs. So enalapril, ramipril, perindopril, moxapril, these are the prodrugs, and इनके active metabolites are enalaprilat, ramiprilat, perindoprilat, moxaprilat, right? Then angiotensin 2 is not formed here, and bradykinin cannot be metabolized, so there will be increasing amount of bradykinin, and ये bradykinin unnecessary side effects करता है, that is dry cough and angioedema. So these are the two side effects that is caused by the bradykinin increase. But अगर ये side effects बहुत ही ज़्यादा आ रहे हैं, then we can give, तो हम कौन सी ड्रग दे सकते हैं? We can give ARBs, हम ये यहाँ ब्लॉक कर सकते हैं। देखो, अगर हम ये चीज़ ब्लॉक कर दें तो एंजियोटेंसिन 2 तक फॉर्म हो रहा है, सो ब्रेडिकाइनिन इज ऑल्सो गेटिंग मेटाबोलाइज, और जब ब्रेडिकाइनिन मेटाबोलाइज हो रहा है तो एक्यूमुलेशन नहीं हो पाएगा, साइड इफेक्ट नहीं आ पाएंगे, राइट। सो इफ पेशेंट इज हैविंग सीवियर ड्राई कफ और एंजियोएडिमा, देन वी विल बी शिफ्टिंग द थेरेपी टू द ARBs, राइट। सो अगर इनिशियली एस इनहिबिटर्स ले रहा था पेशेंट और उसको साइड इफेक्ट्स आ रहे थे, देन वी विल बी शिफ्टिंग इट टू एंजियोटेंसिन रिसेप्टर ब्लॉकर्स, ARBs, राइट। सो फीचर्स की अगर मैं बात करूं, कैप्टोप्रिल इज द निमोनिक, C फॉर कफ, A angioedema, this is because of bradykinin, P prodrugs except captopril and lisinopril, rest all are prodrugs like enalaprilat, ramiprilat, perindoprilat, moxaprilat. Then taste alterations और dysgeusia, जो कोविड का भी एक सिम्टम है, बट इसका भी एस इनहिबिटर्स का भी एक सिम्टम है, टेस्ट ऑल्टरेशन, राइट। देन ऑर्थोस्टैटिक और पोस्चरल हाइपोटेंशन इज ऑल्सो सीन, एंड दीज ड्रग्स आर कॉन्ट्राइंडिकेटेड इन प्रेगनेंसी। जैसे अभी हमने सुबह वाली सेशन में या 2 PM वाले सेशन में बात करी थी कि सेफ एंटी हाइपरटेंसिव ड्रग्स जो है प्रेगनेंसी में वो बहुत ही ज़्यादा लिमिटेड ड्रग्स हैं। ISA वाली बीटा ब्लॉकर्स जो कि कार्डियो सेलेक्टिव है, प्लस निकार्डिपिन, मिथाइल डोपा, क्लोनिडिन, दीज आर फ्यू सेफर ड्रग्स, राइट। एंड एक्लेम्शिया और प्री एक्लेम्शिया के केस में MgSO4 IV, राइट। Then it is also contraindicated in renal artery stenosis. Then it is contraindicated in increased K+, right, because देखो अब ये contraindicated क्यों है K+ में? Because रेनिन का क्या काम था, रेनिन या एल्डोस्टेरॉन का या सबका काम क्या है, क्युमुलेटिव इफेक्ट इज कि Na को ये एब्जॉर्ब कर लेंगे और K+ को ये एक्सक्रीट आउट कर देंगे, बट हियर वी आर ब्लॉकिंग द रेनिन। सो जो एक्सेस Na+ है वो तो डिक्रीज हो जाएगा, वो लॉस्ट हो जाएगा यूरिन में, बट K+ जो है जिसका अर्लियर एक्सक्रीशन हो रहा था उसका एक्सक्रीशन ब्लॉक हो जाएगा, और अगर पेशेंट को हाइपर कैलीमिया ऑलरेडी है, इफ ही इज हैविंग इंक्रीज K+ आयंस इन द बॉडी, सो इसकी क्वांटिटी बढ़ जाएगी, राइट, बिकॉज रेनिन का काम था इसको एक्सक्रीट करना, रेनिन ब्लॉक हो चुका है तो K+ एक्सक्रीट नहीं हो पाएगा, राइट। एंड देन L से इट लोअर्स द रिस्क ऑफ डायबिटिक नेफ्रोपैथी। सो इवन अगर देखो वी जनरली प्रिस्क्राइब दिस ड्रग एज वेल, राइट। सो अगर उसको हाइपरटेंशन और डायबिटीज मेलाइटस दोनों है, देन दिस इज द ड्रग ऑफ चॉइस। एंड इवन अगर उसका हाइपरटेंशन नहीं है, देन वी ट्राई टू गिव दिस ड्रग, to a diabetic, because it kind of reverses the remodeling for the diabetic remodeling as well, right? और टेल मी सार्टन इज द ड्रग जो हम देने की कोशिश करते हैं, वो हम बाद में बात करेंगे. PPAR गामा को स्टिमुलेट करता है, दैट रिवर्सेस द इंसुलिन रेजिस्टेंस एंड दैट इज बेनिफिशियल इन डायबिटीज मेलाइटस. Now captopril, it is the active drug, and it causes fall in BP and more marked when dietary restriction of Na plus is there. It decreases the total peripheral resistance, then it dilate the arterioles, plus it increase the compliance of the larger arteries, and both systolic and diastolic BP falls. Cerebral and coronary blood flow is not compromised, but there are many side effects or many adverse effects like hypotension, hyperkalemia, cough, rashes, urticaria, dysgeusia, fetal growth retardation, that's why contraindicated in pregnancy, headache, nausea, vomiting, granulocytopenia, proteinuria, then acute renal failure, right? Then lisinopril, this is also active drug with captopril, and it is same as captopril, right? All the actions, all the adverse effects are same as captopril, but its duration of action is increased, right? Then enalapril, it is a prodrug. Active metabolite is enalaprilat. It is given IV and it is more potent than these two drugs, right? Perindopril is also a prodrug, long-acting ACE inhibitor with slow onset of action. So it is a long-acting drug, but it is having a slow onset. ये दोनों चीजें डिफरेंट है. लॉन्ग एक्टिंग का मतलब अगर हमने मॉर्निंग 10 AM दी तो बॉडी के अंदर नेक्स्ट डे 10 AM तक ये ड्रग रहेगी, राइट? सो दिस इज अ लॉन्ग एक्टिंग ड्रग, 24 आवर्स ये एक्ट कर रही है, राइट? बट स्लो ऑनसेट क्या होता है? स्लो ऑनसेट का मतलब कि अगर हमने 10 AM पर दी ना तो उसका टाइम ऑफ ऑनसेट हो रहा है 1 PM पर स्टार्ट. सो दिस इज अ स्लो ऑनसेट, मतलब उसको अप्रोक्सीमेटली 3 आवर्स लग रहे हैं मेटाबोलाइज होकर या उसको प्रॉपर अपने आप को अपना एक्शन स्टार्ट करने के लिए उसको 3 घंटे लग रहे हैं, राइट? सो दिस इज अ स्लो ऑनसेट. सो ये दोनों चीज़ें पेरिंडोप्रिल में है. देन यूजेस ऑफ ACIs, यूजेस बहुत ही ज़्यादा इंपॉर्टेंट है यूनिवर्सिटी एग्जाम्स के लिए भी, वाइवा के लिए भी एंड MCQ पॉइंट ऑफ व्यू के लिए भी. Then ACIs is indicated for first hypertension, first line drug है ये and can be used in asthmatics, diabetics and peripheral vascular disease patients. Long term therapy reduce the incidence of type 2 diabetes mellitus. This thing is important. Then secondary hyperaldosteronism and K+ loss is prevented. And in chronic hypertensive patients, left ventricular hypertrophy and increased wall to lumen ratio and blood vessel is reversed. Basically it reverses the remodeling. No hyperuricemia, no rebound hypertension like with clonidine is seen. जैसे clonidine अगर patient ले रहा है, then on sudden stoppage of clonidine he or she can feel rebound hypertension. So no or nothing like that is seen with ACIs, right, on withdrawal, because as it does not block beta receptors, like, so there is no upregulation of any receptors, plus it minimum worsen the life or quality of life. It doesn't worsen the quality of life. Then it reduces the cardiovascular morbidity. It increases the life expectancy of the hypertensive patients. It is suitable for diabetic hypertensives. Then CHF mate is used because of its dilation. It can cause arteriolar and vasodilation both. It reduces the afterload as well as the preload on the heart because of the dilation. Then diuresis also occurs initially because as you all know that रेनिन, देखो इनिशियली जब CHF होता है तो रेनिन बहुत ही हाई अमाउंट्स में सिक्रीट होता है एंड इट रिटेन्स द Na+. सो जो भी इनिशियल में रिटेन करता है वो सब ये बाहर निकाल देता है. right? And H2O, Na plus ये सब lost हो जाता है due to the improved renal perfusion, right? Then ACE inhibitors reduce episodes of the decompensation, myocardial infarction and sudden death. And MI के अंदर भी evolving MI 6 weeks therapy reduce early as well as long term mortality. Unstable angina, NSTMI, long term ACI therapy reduces the recurrent MIs and used for coronary angioplasty as well. Then it is also useful in prophylaxis of the high cardiovascular risk subjects. Ramipril reduce the cardiac death and MI or stroke, or chances of MI or chances of stroke. Then it is really useful in diabetic nephropathy because long-term ACI therapy has been found to prevent or delay the end-stage kidney disease in diabetes mellitus. And albuminuria remaining stable in patients with ACIs and more prominent in diabetes mellitus patient without ACIs. So there is a albuminuria when विद बेसिकली डायबिटीज़ मेलाइटिस के पेशेंट में एल्बुमिनुरिया होने के चांसेस हो सकते हैं और इसके चांसेस बहुत ही ज़्यादा लो हैं अगर हम लॉन्ग टर्म ACIs की थेरेपी चला रहे हैं. देन ट्रीटेड पेशेंट हैज़ इंक्रीज्ड क्रिएटिन क्लियरेंस and require less dialysis and have longer life expectancy, right? So diabetes mellitus के patient के अंदर it increases the life expectancy. And then it decreases the intraglomerular pressure as well. All the diabetic patients, whether hypertensive or normotensive, deserve ACIs. So this thing I was telling you in my last or second last slide. And it reduces the chances of diabetic retinopathy, nephropathy, right? And it is also useful in scleroderma crisis. Marked rise in, so scleroderma crisis is when you see marked rise in BP and deterioration of the renal function. So it is mediated by the angiotensin 2, right? And angiotensin 2 का formation is due to ACE. So we will be giving ACE inhibitors that produce a dramatic improvement and all the life saving in this condition. So captopril test to find the need of renal angiography for the diagnosis of renovascular hypertension. Acute blockade of angiotensin 2 formation by captopril results in reactive increase in PRA. PRA is much higher in renovascular disorder than essential hypertension. So that's why we can do a captopril test, but medical point of view से नहीं use होता, right? Now comes the ARBs. तो इसके अंदर सब कुछ सेम होता है, बस साइड इफेक्ट जो एंजियोडीमा और ड्राई कफ वाले आते हैं, दैट इज ड्यू टू ब्रेडिकाइनिन, वो नहीं आते. So ARBs or angiotensin receptor blockers or AT1 blockers, and it comprises of all the drugs that जिसका end में आता है sartan. So the drugs are losartan, valsartan, telmisartan, irbesartan, eprosartan, candlesartan, olmesartan. And इसके अंदर there is an exception, or there is my favorite drug, that is telmisartan, because it is having two effects. One is ARB wala effect, and the second effect is it stimulates the PPAR gamma, and ये PPAR gamma को stimulate करता है, that's why it reverses the insulin resistance, and thus it is beneficial in reversing in the insulin resistance. It is beneficial in type 2 diabetes mellitus, right? So thus this is the drug that is really beneficial. Angiotensin 1 gets converted to angiotensin 2 with the help of ACE, and simultaneously bradykinin is metabolized, and angiotensin 2 comes to AT1 receptor and it produces its action, but हम इसको block कर देंगे ताकि कोई भी action produce ना हो, and it is beneficial than ACIs because no side effect like angioedema or dry cough is are produced, right? So features, उसके अंदर सब features थे कैप्टोप्रिल वाले, बट इसके अंदर टोप्रिल, right? Taste alteration is seen, orthostatic postural hypotension is seen. It is also contraindicated in pregnancy. It is also contraindicated in renal artery stenosis. It is also contraindicated in hyperkalemic patients, and it lowers the risk of diabetic nephropathy, right? And uses of ARB is same as ACIs, hypertension, MI, diabetic nephropathy, but in diabetic mellitus patients, then we try to give telmisartan because it is having both the things, both the actions, right? And it blocks the AT1, stimulates the PPR alpha, and used to reverse the insulin resistance, and so useful in diabetic patients, right? And now comes the direct renin inhibitor, Aliskiran. So this blocks the renin at the second step, right? जहाँ हम जैसे हमने बात करी थी बीटा 1 स्टिमुलेट होते हैं JG cells पर, and with few stimulus, and the stimulus is Na deficiency or increased loss of NaCl or blood volume का कम हो जाना, serum volume का कम हो जाना. So beta 1 on the JG cells are stimulated and they produce the renin. Renin को ये block कर देता है directly जाके. So ये इसके आगे कोई भी functions नहीं होते, right? And it competitively blocks the renin. Therefore angiotensin 1 is not produced. Concentration of renin in plasma is increased by feedback mechanism. The plasma renin activity is decreased, right? Plasma renin activity is decreased, and it increases the natriuresis, hyperkalemia, fall in BP, and renoprotective in diabetes mellitus and hypertension both. So they both, all the three, they are renoprotective, right? All the three drugs, ACIs also, ARBs also, Aliskiren also. So these three drugs are renoprotective. Adverse effect की अगर मैं बात करूँ, same as ACIs but less frequent. Now comes the sympathetic blocker. So here we are blocking the first step only, right? So हम पूरा का पूरा mechanism को चलने से पहले ही block कर देंगे, हम beta 1 को ही block कर देंगे, and the drugs are propranolol, sotalol and timolol. So these are the renin release inhibitors, but Aliskiren is direct renin inhibitor. So it directly inhibits the renin. But अगर हम बीटा ब्लॉकर दे रहे हैं तो रेनिन के रिलीज को इनहिबिट कर रहा है वो, राइट? Then we can give adrenergic neuron blockers as well, reserpine, guanethidine and bretylium. Then we can also give sympatholytics, but this we generally not give, phenoxybenzamine and phentolamine. Then fifth, aldosterone antagonist, K plus pairing diuretics, that the drugs are spironolactone and aplerenone. So aldosterone antagonist, K plus pairing diuretics, and the drugs are spironolactone and aplerenone. These अगर हम ये ड्रग देंगे, so this will be blocking the remodeling, right? Then there are few newer drugs. First is BNP, brain natriuretic factor, causes natriuresis, Na loss and can cause vasodilation. BNP का डिग्रेडेशन होता है NEP से, नेप्रिलाइसिन से. सो देखो, एक तो हम BNP का एनालॉग दे सकते हैं, और वी कैन गिव नेप्रिलाइसिन इनहिबिटर्स. सो क्या कर रहा है ये? इट कैन कॉज नाट्रियूराइसिस, और Na लॉस ही हमें करवाना है बिकॉज Na का रिटेंशन हो चुका है ड्यू टू इंक्रीज्ड रेनिन रिलीज. सो वी वांट टू एक्सक्रीट द Na आउट, एंड द सेकेंड थिंग इज हमें वेजो कॉन्स्ट्रिक्शन को रिवर्स करना है. So that's why we'll be giving vasodilator. So that's why हम BNP देंगे, because it possesses a vasodilator action as well, right? देन BNP NEP से मेटाबोलाइज होगा, डिग्रेड होगा, और हम BNP को बढ़ाने के लिए उसका एक रिकॉम्बिनेंट एनालॉग दे सकते हैं, दैट इज नेस्टिराइड. Nesteride is the analog of the BNP. It is given through IV route, short acting, and used for acute cases. Then to increase BNP, we can give neprilysin inhibitors as well, that is sacubitril and icadotril. And then third, we can give vasopeptidase inhibitors, so they inhibit the ACE inhibitors and NEP. So ये दो चीज़ें करती हैं, ACE को भी ब्लॉक कर देगा और NEP को भी ब्लॉक कर देगा. सो BNP भी बढ़ेगा बॉडी के अंदर, और जो ACE की वजह से साइड इफेक्ट्स आ रहे थे या एंजियोटेंसिन 2 की वजह से साइड इफेक्ट्स आ रहे थे वो भी नहीं आएंगे. So omapatrilat or sampatrilat, these are the newer drugs, and as they are blocking ACE, so इनका भी side effect आएगा, angioedema and cough, right? Then we are having ERNI का मतलब है angiotensin receptor blocker plus NEP inhibitor, ARNI, ERNI, angiotensin receptor blocker with NEP inhibitor. So we are combining the two drugs here, valsartan, that is IARB, and sacubitril, that is a NEP inhibitor. So हमने नई ड्रग्स कौन सी बात करी, नेस्टिराइड, sacubitril, icadotril, omamatril, sampatril, then vampa, what I am saying, then valsartan and sacubitril, right? So ERNI, vasopeptidase inhibitor, then nesteride, and then NEP inhibitors. So these are the newer drugs. Now comes arrhythmia. So anti-arrhythmic drugs, right? First of all, what is arrhythmia? What is arrhythmia? In easiest language, what is arrhythmia? फटाफट से चैट में बताओ. Yeah, we are having an answer, that is irregular cardiac rhythm. So arrhythmia is, in the simplest language, is irregular cardiac rhythm. Yes, you are right, tech number. So arrhythmia is irregular cardiac rhythm, and its etiology lies behind that there can be abnormal automaticity or impaired conduction or both. So कार्डियक रिदम इरेगुलर क्यों हो रही है? फर्स्ट ऑफ ऑल, इम्पल्स जनरेट कहां से हो रहा है? सो देयर इज अ इरेगुलर इम्पल्स बेसिकली, राइट? सो इम्पल्स जनरेट कहां से होता है? एसए नोड से, देन इट गोज टू एवी नोड, देन इट गोज टू बंडल ऑफ हेज, देन इट गोज टू परकिंजी फाइबर्स, राइट? सो आइदर देयर इज pathology in impulse generation. So impulse generation में अगर प्रॉब्लम आ गई, ऐसे नोड में प्रॉब्लम आ गई, then there can be arrhythmia. प्लस अगर कंडक्शन के टाइम पर कोई प्रॉब्लम आ गई, then there can be arrhythmia, right? Here only let me discuss the normal heart rate. So normal heart rate ranges from 60 to 100 beats per minute. If it is less than 60, then you will be referring it as bradycardia, and if it is more than 100, then you will be referring it as tachycardia. And ये slide थोड़ी सी हिल गई, I don't know why, so please don't mind. So there are few important types of cardiac arrhythmia. First is extrasystole, then PSVT or paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillation, ventricular fibrillation, AV block, TORS, DSG pointes. So these are few important types of arrhythmias, राइट. फर्स्ट इज एक्स्ट्रासिस्टोल. एक्स्ट्रासिस्टोल गाइस तब आता है जब यू कैन सी अ प्रीमेच्योर एक्टोपिक बीट और एबनॉर्मल बीट जो कि नॉर्मल ईसीजी में आपको दिख रही है. राइट. सो इट इज अ एबनॉर्मल बीट that you are seeing is in a normal ECG. So it is a premature ectopic beat due to any abnormal atomicity arising from the ectopic focus. So कई बार क्या होता है, abnormal focus generate हो जाता है within heart, so that is ejecting or that is producing impulses. So that is a premature impulse. एंड एक्टोपिक का मतलब अदर देन द नॉर्मल साइट्स, कोई भी एबनॉर्मल साइट पर जनरेट हो चुका है. सो दैट्स व्हाई दैट इज अ एबनॉर्मल एक्टोपिक इम्पल्स जनरेटर. सो अगर वो एट्रियम में जनरेट हुआ है देन एट्रियल एक्स्ट्रासिस्टोल, वेंट्रिकल में हुआ है देन यू विल बी रेफरिंग इट एज वेंट्रिकल एक्स्ट्रासिस्टोल, एवी नोड में हुआ है देन यू विल बी रेफरिंग इट एज एवी नोडल एक्स्ट्रासिस्टोल. राइट. So extrasystoles are the premature ectopic beats that are originating from the abnormal focus or abnormal ectopic focus, and if the abnormal ectopic focus in atrium then you will be referring it as atrial extrasystole. If it is in a ventricle then you will be referring it as ventricle extrasystole. If it is there in AV node then AV nodal extrasystole. Second is paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia का मतलब when your heart rate is 150 to 200 but 1:1 AV conduction. So if your atrium is beating at 100 beats per minute or 150 beats per minute, then your ventricle will also beat at 150 beats per minute only. Right. So there is a sudden onset of atrial tachycardia with 1:1 AV conduction. 1:1 AV conduction. This is important, and due to the circular movement of ions in the AV node and around it. So there is a Wolff Parkinson White syndrome जिसके अंदर भी यही चीज होती है. Then atrial flutter when atria is beating at the rate of 200 to 350 beats per minute. Atrial fibrillation when rate is 350 to 550 beats per minute, and most common chronic arrhythmia is atrial fibrillation. Then ventricular fibrillation, most common cause of sudden cardiac death. So when your ventricle is beating at 350 to 550 beats per minute, then there are high chances कि sudden cardiac death हो सकती है. एक एग्जाम्पल लेते हैं. दिस इज द हार्ट. एक सेकेंड में देख लूँ कि इट इज विजिबल इन वीडियो और नॉट. वेट अ फ्यू सेकेंड्स, ये थोड़ा लैग करता है ना. या सो नॉर्मल हार्ट जो है, नॉर्मल हार्ट अगर बीट कर रहा है, सो नॉर्मल हार्ट पहले रिलैक्स करेगा, ब्लड फिल होगा, फिर अच्छे से कॉन्ट्रैक्शन होगा, फिर रिलैक्सेशन होगा, कॉन्ट्रैक्शन होगा, रिलैक्सेशन होगा, कॉन्ट्रैक्शन होगा, एंड दिस रिलैक्सेशन एंड कॉन्ट्रैक्शन टेक्स टाइम. राइट. दैट्स व्हाई आवर नॉर्मल beat is from 75 to 98, right, or 65 to 98. So that is a normal heartbeat. So it takes time. But अगर if your heart is beating at 500 beats per minute, so आपका heart proper contraction relaxation कर ही नहीं पाएगा. So it will be beating like this. So असली में ऐसे ही बीट करेगा हार्ट. तो आपको क्या लगता है कि ये ऐसे प्रॉपर कॉन्ट्रैक्शन रिलैक्सेशन कर पाएगा? नहीं कर पाएगा. दैट्स वाई कितना ब्लड ये पंप कर पाएगा आगे? वेरी लेस अमाउंट. दैट्स वाई देयर आर हाई चांसेस ऑफ सडन कार्डियक डेथ. राइट. एंड AV ब्लॉक की अगर बात करें तो देर आर 3 डिग्रीज ऑफ AV ब्लॉक. फर्स्ट डिग्री, सेकेंड डिग्री, थर्ड डिग्री. फर्स्ट डिग्री इज व्हेन यू कैन सी prolonged PR interval. Second degree में you can see a drop beat. It is of 2 types, Morbid's type 1 and Morbid's type 2. देन थर्ड डिग्री में इट इज रेफर्ड एज कंप्लीट आर्ट ब्लॉक, बिकॉज कहीं पर भी पी आ रही है, कहीं पर भी क्यू आर एस कॉम्प्लेक्स आ रहा है, कहीं पर भी टी आ रही है, सो दैट्स वाई. Then Torsades de Pointes, it is a QT prolongation and hypomagnesemia, and it is due to hypomagnesemia and hypokalemia, and it predisposes to the, so a condition like hypomagnesemia and hypokalemia predisposes the Torsades de Pointes. And I want to show you ECG of Torsades de Pointes. It's on my phone, I think, yeah. So it's on my phone, and this is the normal, this is a Torsades de Pointes wala ECG. So I hope this is visible to you all, right? So this is a perfect ECG of Torsades de Pointes. आई थिंक ये विजिबल नहीं हुआ होगा, थोड़ा सा आगे लेके चलते हैं. हाँ, आई थिंक नाउ इट इज विजिबल. लेट्स सी. let's see. हाँ, नाउ इट इज विजिबल. और यहीं पर मैं आपको एक और ईसीजी दिखाऊंगा जो कि है एट्रियल फ्लटर की. सो दिस इज द ईसीजी ऑफ एट्रियल फ्लटर. राइट. Yeah, both the ECGs are visible on phone, right? हाँ. So guys, Torsades de Pointes की हमने बात कर ली, and now let's talk about the physiology or cardiac action potential, because if we want to study the antiarrhythmic drugs, then this is the must learn thing. So guys, cardiac action potential comprises of 4 phases: phase 0, phase 1, phase 2, phase 3. phase 0 के अंदर there is sodium influx, right? And it is so rapid that आपको यहाँ एक straight line दिख रही है, and it is a rapid depolarization, right? So एक सेल के अंदर इतना ज़्यादा पॉजिटिव चार्ज नहीं सस्टेन कर सकता. सेल कैन नॉट सस्टेन द दिस हाई अमाउंट ऑफ पॉजिटिव चार्ज. सो इमीडिएटली कुछ पॉजिटिव चार्ज बाहर निकल जाता है, सो कुछ K+ बाहर निकल जाते हैं, बिकॉज सोडियम तो एक बाहुबली है, ये बाहर नहीं जाएगा. K को बाहर जाना पड़ता है, और तभी आपको यहाँ पर एक ड्रॉप दिखता है, दैट इज रैपिड रीपोलराइजेशन का ड्रॉप. That is phase 1, that is due to the immediate sudden K+ efflux, right? And then you can see here phase 2. phase 2 के अंदर क्या होता है कि as potential difference जो है वो maintain हो जाता है across the membrane, so there is a K+ efflux and calcium का influx. So some positive charge is going out and some is coming in. So there is a normal charges are maintained, और एक neutrals are maintain हो जाता है. So that's why you can see here plateau phase, right? Then phase 3 और repolarization वाला phase. So this phase is due to K+ efflux. This phase is due to K+ efflux, right? And immediate होता है, तभी आपको यहाँ एक drop दिख रहा है. So we have discussed about phase 0, phase 1, phase 2, phase 3 and phase 3, sorry. So now how the drugs can act. So there are 3 types of drugs. First is sodium blocker, potassium blocker, potassium opener. So if we talk about sodium blocker, then how a sodium blocker drug will act. आप बताओ मुझे. Sodium is the Bahubali ion, and sodium is the only ion that causes depolarization, and because of sodium there is the straight line of phase 0. So if we will be giving sodium blocker, then what will happen? अगर हम सोडियम ब्लॉकर दे रहे हैं तो क्या होगा? सो वेट अ सेकेंड गाइज, मेरा जो फोन है वो स्विच ऑफ हो चुका है, एंड एक सेकेंड में मैं इसको चार्जिंग पे लगा देता हूँ. सो गाइज, सोडियम चैनल ब्लॉकर्स कैसे एक्ट करते हैं? सो सोडियम चैनल अगर हम ब्लॉक कर देंगे तो देयर विल बी स्लो इनफ्लक्स ऑफ सोडियम, एंड अगर स्लो इनफ्लक्स होगा सोडियम का, देन देयर विल बी स्लो डीपोलराइजेशन. स्लो डीपोलराइजेशन की वजह से जो स्ट्रेट लाइन है ये नहीं देखने को मिलेगी, हमें एक स्लैंट लाइन देखने को मिलेगी. So slope will be decreased, dV by dt will decrease, and thus there will be slow repolarization, और peculiar graph ये आएगा, right? And this is due to slow depolarization, and slope will also decrease, dV by dt will also decrease. dV by dt is nothing, dV by dt is slope only. Then K plus blocker की बात करते हैं. So K plus is the ion that is the repolarization वाला ion that causes the repolarization, right? Then K plus blocker अगर देंगे then slow repolarization होगा because channels block हो जाएंगे, right? And slow repolarization की वजह से AP duration will be increased. एंड इनिशियली अगर आपका यहाँ पर फेज 3 ख़त्म हो रहा था, तो अब बहुत ही ज़्यादा टाइम लगेगा, एक्शन पोटेंशियल ड्यूरेशन इंक्रीज हो जाएगी. एंड इफ़ वी विल बी टेकिंग दिस थिंग ऑन ECG, देन यू विल बी सीइंग QT prolongation. And earlier we have already studied that QT prolongation can cause Torsades de Pointes. So K plus blockers, if we will be using these drugs chronically, then there will be a Torsades de Pointes. And yeah, antiarrhythmic drugs can itself cause arrhythmia because of this mechanism only, right? Let me see the live chat, and then we will be continuing further. What's wrong with this? Wait a second, guys. Yeah. So here you can see that this is the normal ECG, normal P wave, normal QRS, and then T, and after that जो नीचे वाला है उसमें देखो, you can see QT prolongation है, right? QT prolong हो चुका है, right? इतना, right? But इससे भी काफ़ी ज़्यादा होता है. This is a pictorial representation. And now, do you know the drug that can cause Torsades de Pointes? And that's why, because of this side effect, ये withdraw हो चुकी है. This drug comes under antihistaminic group. So बताओ. और एक और हिंट दूं तो इसका न्यूअर डेरिवेटिव इज फेक्सोफेनाडीन, एंड वो कम चांसेस हैं कि टॉर्सिडीज डी पॉइंटिस करे, राइट? सो व्हाट इज दैट ड्रग, गाइस? what is that drug, guys? So we are having our answer, that is terfenadine. And yeah, terfenadine is correct, and its neo derivative is fexofenadine. टर्फेनाडीन था जो हर एक ड्रग इवन स्मॉल क्वांटिटी लार्जर क्वांटिटी में इट वाज कॉजिंग टॉर्सिडीज डी पॉइंटिस. नाउ कम्स द के प्लस ओपनर और द थर्ड टाइप ऑफ द ड्रग. सो हमने अभी तक डिस्कस करा है Na प्लस ब्लॉकर कैसे एक्ट करते हैं, कैसा ग्राफ मिलेगा, के प्लस ब्लॉकर कैसे एक्ट करते हैं, कैसा ग्राफ मिलेगा, और नाउ वी विल बी टॉकिंग अबाउट के प्लस ओपनर. So guys, K plus opener they causes the rapid repolarization, and rapid repolarization होगा मतलब कि चैनल खुल गए सारे के सारे, K plus will be moving out right at increased pace. That's why there will be rapid repolarization और action potential duration decrease हो जाएगी इसकी वजह से. And if we take this thing on ECG तो QT interval भी decrease हो जाएगा, और as such it cannot cause any arrhythmia, right? So now comes the drug classification. Now comes finally the drug classification or Vaughan-Williams classification. So Vaughan-Williams ने 5 क्लासेस में ड्रग्स करी थी क्लासीफाई. सो फर्स्ट क्लास के अंदर द ड्रग्स आर सोडियम चैनल ब्लॉकर, क्लास सेकेंड कंप्राइजेस ऑफ बीटा ब्लॉकर्स, क्लास थर्ड कंप्राइजेस ऑफ potassium blockers, class 4 calcium channel blocker or L type calcium channel blockers, class 5 others, and in this we are having 3 drugs AAD, add drugs. So first is atropine, adenosine, that is ultra short acting, and then digoxin, the versatile drug, right? So now comes the class 1 or the sodium channel blocker drugs. It is having 3 subclasses further. So sodium channel blockers, they will be decreasing the slope and they will be decreasing the dV by dt, right? And they are of 3 classes and they are subclassified under 3 sections, A, B and C. First, that is A section, ये थोड़ा सा टॉपर वाला सेक्शन है. इट विल बी ब्लॉकिंग सोडियम एंड इट विल बी ब्लॉकिंग पोटेशियम बोथ. सो सोडियम ब्लॉकिंग की वजह से स्लोप विल बी डिक्रीज्ड, पोटेशियम ब्लॉकिंग की वजह से एक्शन पोटेंशियल विल बी इंक्रीज्ड, राइट? एंड दस एक्शन पोटेंशियल ड्यूरेशन बढ़ गया तो QT इंटरवल विल बी इंक्रीज्ड, टॉर्सिडीज डी पॉइंटेज के चांसेस हैं. क्लास बी की अगर बात करें तो इट इज कम्पिटिटर इन नेचर. सो Na को तो ब्लॉक करता है बट पोटेशियम को ये ओपन करता है, राइट? सो एज सच सोडियम ब्लॉकिंग की वजह से स्लोप डिक्रीज हुई, पोटेशियम ओपनिंग की वजह से एक्शन पोटेंशियल ड्यूरेशन डिक्रीज हुआ, राइट? बट एज सच कोई भी फर्दर इफेक्ट नहीं आया. Class C, that is the निकम्मा section of the all the classes. So C section सिर्फ Na block करेगा and thus only it will be decreasing the slope and dV by dt, और कोई action produce नहीं करेगा ये, right? So A is having 2 actions, B is having 2 actions, C is having 1 action. A is blocking both sodium and potassium, B is blocking sodium and opening potassium, but C is only blocking sodium, right? So class 2, that is beta blocker, it depresses the heart and thus it is a drug of choice in tachyarrhythmias. Potassium channel blocker or class 3 drugs, they causes torsides de pointis as their side effects. Class 4, that is L type calcium channel blocker, they depresses the heart and thus it is having same indication as class 2 and they are used in tachyarrhythmias. Then class 5 or others group, digoxin, digoxin is there, atropine is there, adenosine is there. Digoxin का काफ़ी सारे actions होते हैं, but the action that is used to prevent arrhythmia or that is used in arrhythmia is it decreases the AV conduction, so it decreases the atrial का जो conduction है to the ventricle, so it kind of prevent the condition that can be secondary to the atrial conduction, atrial fibrillation. So initially क्या होता है guys, atrial fibrillation हो रहा है patient को, तो it can transmit it to the ventricle as well. So अगर patient को atrial fibrillation है, then वो ventricle fibrillation में भी convert हो सकता है, and if you want to prevent this thing, then digoxin is the drug that will be preventing this thing. But digoxin इसको normal sinus rhythm में नहीं ला सकता. नॉर्मल साइनस रिदम में एट्रियल फिब्रिलेशन से नहीं ला सकता डिगॉक्सिन. ओनली डिगॉक्सिन कैन डू इज डिगॉक्सिन कैन प्रिवेंट द कंडक्शन और इट कैन स्लो द एवी कंडक्शन. Atropine is the drug that is drug of choice for bradyarrhythmia, and adenosine is the ultra short acting drug. Its free half life is only 10 seconds, and it is the drug of choice for paroxysmal supraventricular tachyarrhythmia or tachycardia. So it is administered in the central veins, right? Now class 1 or sodium channel blocker. So it is having 3 classes as I said. First one is K plus blocker, sodium blocker. Second one is sodium blocker, K plus opener, and third one is sodium blocker. So drugs that comes under A section is quinidine and procainamide, and they are having a potential that they can cause Torsades de Pointes. Plus in B class, drugs comes are lignocaine or lidocaine, phenytoin and tokainide, and it is drug of choice for ventricular arrhythmia. Lignocaine is the life-saving drug when it is administered IV during the cases of ventricular tachyarrhythmias. So when there is a ventricular tachyarrhythmia, so जो ventricle है वो बहुत ही जल्दी fail हो जाता है, and there are more than 99% chances की sudden death हो सकती है. So the life saving drug is lignocaine, and C section is not having any other action, and the drugs that comes under C section is encainide, flecainide, propafenone, right? So guys, quinidine is indicated for the atrial and ventricular arrhythmias, and it can cause Torsades de Pointes. It can cause ventricular fibrillation as a side effect, and it can cause sudden cardiac arrest. Then it can also cause angioedema, vascular collapse, thrombocytopenia, and mechanism of action is by both of its actions. It by blocking sodium, it decreases the slope and it decreases the dV by dt, and by blocking potassium, it increases the action potential duration, QT interval, Torsades de Pointes. Plus it also decreases in the ectopic automaticity, so that's why it is also useful in extrasystoles, right? And it is also having a alpha blocking property, and with this it can cause fall in BP, right? लाइव चैट में क्या चल रहा है एक बार वो देख लेते हैं. So now comes procainamide. Procainamide is also indicated for ventricular tachyarrhythmia and PSVT, but drug of choice for PSVT is adenosine. That is for emergency treatment. And adverse effects are if you will be using it as long-term therapy. So there are high chances of systemic lupus erythematosus. Plus it can cause nausea and vomiting and hallucination and confusion and Torsades de Pointes as well, because it is having action on K plus blocking. Subclass IB that blocks sodium and open the K plus. It will be having 3 drugs: lidocaine, phenytoin, tokainide, and thus it will be decreasing the slope and decreasing the action potential duration, because due to Na plus blocking there will be decreased slope, and due to K plus blocking there will be decreased action potential duration. Then it decreases the ERP and QT interval as well. And lidocaine or lignocaine is indicated for the ventricular tachyarrhythmia, and it prevents the ventricular fibrillation, and it prevents the sudden cardiac death. Right. Plus it prevent the arrhythmia following the acute MI or post MI arrhythmia के अंदर it is useful. Then adverse effects की बात करूँ, then it is having a fewer adverse effects: drowsiness, nausea, paresthesia, blurred vision, disorientation, nystagmus and twitching. So these all are the adverse effects of lidocaine. सब क्लास IC की अगर मैं बात करूँ, then sodium blocking is only seen here. So only typical graph is there, that is only decreasing its slope. No action will be seen on the action potential duration. And the drugs are propafenone, enkenyde and flecainide. And these are indicated in the ventricular extrasystoles and ventricular tachycardia, and they are useful in maintaining the sinus rhythm. And thus prophylaxis or prophylactic treatment of PSVT. Side effect की अगर मैं बात करूँ तो nausea, vomiting, bitter taste, constipation and blurred vision is there. Then class 1. So then class 2 comes beta blocker drugs, comes propranolol, esmolol. So propranolol is indicated for the tachyarrhythmia, sinus tachycardia, atrial and nodal extrasystoles, pheochromocytomas, arrhythmias, and during anesthesia with halothane. So when you give anesthesia with halothane, there are high chances of causing arrhythmias. So that's why if your patient is having arrhythmia after the administration of anesthesia halothane, so you will be giving propranolol. Then digitalis induced arrhythmia or digoxin induced arrhythmia, then thyrotoxicosis की वजह से जो arrhythmia होता है, it is also treated with propranolol. Then IV propranolol is useful in suppressing the Torsades de Pointes, right? But the drug of choice for Torsades de Pointes is MgSO4. Then ECG के अंदर क्या दिखेगा आपको? If you are giving propranolol, so on ECG there will be prolongation of the PR interval and decrease or depression of the cardiac contractility. Esmolol is indicated for the emergency control of the ventricular rate in atrial flutter and atrial fibrillation. It terminates the supraventricular tachycardia and arrhythmias associated with anesthesias. So propranolol was indicated for tachyarrhythmia, sinus tachycardia, atrial and nodal extrasystoles, pheochromocytoma, and anesthesia-induced arrhythmia, digitalis-induced arrhythmia, and thyrotoxicosis-induced arrhythmia. But esmolol is indicated in the emergency control for the ventricular rate in atrial flutter and atrial fibrillation, then for the termination of the supraventricular tachycardia, and then arrhythmia associated with the anesthesia. That is same as propranolol. Last indication is same as propranolol. Then class 3 or K plus blocking drug, that is having a main action as QT interval prolongation, Torsades de Pointes, action potential duration increase करता है, slow repolarization करता है. So this is the main mechanism. But the thing is the drugs. It is having bindas drugs. B for bretylium, I for ibutylide, D for dofetilide, A for amiodarone, S for sotalol. And amiodarone का newer derivative is drondarone. So it consists of bindas drugs, and bretylium is pharmacological defibrillator. Ibutylide and dofetilide are indicated for the atrial fibrillation, and they are having the potential to convert the atrial fibrillation to the normal sinus rhythm. right? So ibutylide and dofetilide, they are having the potential that they can convert the atrial fibrillation to normal sinus rhythm. And जो amiodarone है, amiodarone is having many mechanism of action and many side effects. So we will be taking it after this topic. मतलब ये वाला slide खत्म करने के बाद हम लेंगे. And its newer derivative is neurodronderone, that is safer. Then sotalol. Sotalol is the beta blocker, right? It ends with olol. So अब आप कहोगे कि तो beta blocker है. Then why it is grouped under K plus blocking drugs? Why? Because sotalol is a beta blocker, but the main antiarrhythmic action of sotalol is due to K plus blocking. So guys, sotalol is a beta blocker, but its antiarrhythmic action is due to K plus blocking. So that's why sotalol is grouped under K plus blocking drugs, right? Or group 3, right? Because here we are talking about anti-arrhythmicity of the drug. So sotalol का जो anti-arrhythmic action है, that is due to K plus blocking, not because of beta blocking, right? Now comes the amiodarone. Amiodarone is an iodine containing highly lipophilic long acting antiarrhythmic drug, and it is multi-channel blocker. It acts through each and every mechanism, and it exerts many actions, like it exerts from the class 1 like class 1 drug. It blocks the Na, it blocks the K, it blocks the beta receptor, it blocks the calcium channels and all of that. So that's why it is having much more side effects. So it prolongs the action potential duration and QT interval because of K plus blocking, right? And it partially inhibits the myocardial calcium channels as well, right? So adverse effects की अगर हम बात करें तो सबसे पहले आँख आती है. So it can cause corneal deposits, and thus it can cause headlight dazzle, right? Then आँख के बाद आता है thyroid gland, and it is iodine containing, so this drug is goitrogenic. It can cause hypothyroidism and hyperthyroidism, and कुछ individuals के अंदर it was causing hypothyroidism, कुछ individuals के अंदर it was causing hyperthyroidism, right? Then thyroid के नीचे आता है heart, and heart को ये depress करता है. It depresses the myocardial muscles. Then हार्ट के आसपास आते हैं लंग्स. इट कॉजेस लंग्स का फाइब्रोसिस. लंग्स के नीचे आता है लीवर. लीवर में इट कॉज टॉक्सिसिटी. नाउ अब आता है स्किन. सो बेसिकली फर्स्ट ऑफ ऑल इट कॉजेस द पेरिफेरल न्यूरोपैथी, एंड स्किन पे इट इज फोटोसेंसिटिव and it can cause rashes, plus it can cause blue man syndrome or bluish discoloration of the skin. And here only I want to ask you that which drug can cause red man syndrome? So the drug is vancomycin. Vancomycin is the drug that can cause red man syndrome. And amiodarone is indicated for the ventricular tachycardia, PSVT, and nodal extrasystoles, atrial fibrillation, atrial flutter, resistant ventricular tachycardia, and recurrent ventricular fibrillation. So it is having much more indications, and it is really a potent drug, right? So ये potent drug है. So हमें इसको lose नहीं करना because of its side effects. So we developed its newer derivative, that is dronderone. or it is a non-iodinated डेरिवेटिव ऑफ एमियोडेरॉन, इट इज लेस टॉक्सिक, और ये आयोडीनेटेड नहीं है तो थायराइड पर भी कोई एक्शन प्रोड्यूस नहीं करती, एंड इट डज नॉट इंटरफेयर विथ थायराइड फंक्शन. एंड contraindication, it is contraindicated when the patient is having moderate to severe CHF and second or third AV block and permanent atrial fibrillation. And then class 4 comes calcium channel blockers, and what is that called? Most appropriately L-type calcium channel blocker, because calcium channel receptors are of two types, 1 and 2, or T or L. L-type are on heart and T-type are on CNS tissue. So here we will be going to use L-type calcium channel blockers. So drugs are verapamil, diltiazem and DHPs, and they depresses the heart, and thus they are indicated in tachyarrhythmias. Verapamil suppresses the automaticity, and it is negative inotropic drug, and action due to the interference with the calcium channel mediated excitation contraction coupling in the myocardium. So its action is produced by interfering with the excitation and contraction coupling thing, right? So this may precipitate the failure in the damaged heart. Basically that's why it is not used in CHF. CHF के अंदर हम use करेंगे, then they will be decreasing the inotropicity. But here our aim of the treatment is to increase the inotropicity. Right, we want to increase the inotropicity. Then indication of the drugs, indication is PSVT, 5 mg IV over 2 to 3 minutes is effective in more than 80 cases, but drug of choice for PSVT is adenosine. And emergency control of ventricular rate in atrial fibrillation, atrial flutter and atrial fibrillation, right? Adverse effects are, it can produce bradycardia, AV block, cardiac arrest and hypotension. Contraindications, PSVT is accompanied by hypotension or CHF and broad QRS complex, Wolff-Parkinson-White tachycardia or syndrome, then partial heart block and sixth sinus syndrome. So it is contraindicated when PSVT is accompanied by hypotension or CHF, broad QRS complex, Wolff-Parkinson-White syndrome, sixth sinus syndrome and partial heart block, because it depresses the heart. So that's why. Diltiazem is indicated for the termination and the prophylaxis of PSVT. It can rapidly control the ventricular rate in atrial fibrillation and atrial flutter. And then class 5 comes, और adenosine और atropine और digoxin वाली add वाली drugs आ गई अब. So digoxin is used for the prevention of the ventricular fibrillation in case of atrial fibrillation, because it it depresses the thing. It depresses the AV conduction, right? So it depresses the AV conduction. Wait a second, chart में पर देख लेना है तो yeah. So digoxin is used for the prevention of ventricular fibrillation in case of atrial fibrillation. So जैसे कि मैंने कहा कि अगर पेशेंट को atrial fibrillation है, then there are high chances that it can cause ventricular fibrillation as well, and we want to prevent this thing. So we will be giving digoxin. But मैं बार बार कह रहा हूँ, digoxin normal sinus rhythm नहीं बना सकता, normal sinus rhythm नहीं generate कर सकता. Then atropine. Atropine is the only drug that is indicated for the bradyarrhythmia. Till now we have studied every drug about tachyarrhythmia or tachycardia, right? And atropine is the only drug that is indicated in the bradyarrhythmia, right? Then adenosine. Adenosine is the ultra short acting drug. Its T half life is 10 seconds. and thus it is administered in the central veins. And इसकी अगर हम indications देखें, then adenosine is the drug of choice for PSVT emergency treatment and not suitable for the prophylaxis. AV node की अगर मैं बात करूं, then it is also indicated in the AV node dependent tachycardias as well. Then brief coronary vasodilation is the interventional procedures के अंदर भी it is indicated, and to produce a control hypotension during surgery, because we don't want excessive blood loss, so we want controlled hypotension, so that's why it is indicated in this. So guys, there are 4 indications. First is PSVT, then AV node dependent tachycardia, and then brief coronary vasodilation or interventional procedures maybe, and to produce a controlled hypotension during surgery. But it activates the ACH sensitive K plus channels, and influx of K plus is there that causes hyperpolarization, and through interaction with A1 receptors, and A1 receptors are G protein coupled receptors on the SA node and AV node. So SA node को अगर ये interact करेगा, then it will be producing bradycardia, and AV node से करेगा तो slowing of the AV conduction will be produced. So इसके 3 effects हैं. First of all, it will be doing hyperpolarization, then bradycardia will be seen, then slowing of the AV conduction will be there, and it reduces the calcium current in AV node, and with this we can produce a controlled coronary vasodilation, like controlled hypotension, right? But there is a disadvantage. The person who takes tea, coffee and caffeine, they block their A1 receptors, so they need a high quantity, higher doses of adenosine. Then adverse effect की अगर मैं बात करूँ, then transient dyspnea, flushing, hypotension and chest pain. Contraindication की अगर मैं बात करूँ, then it is contraindicated in asthmatics, because bronchospasm, they can cause bronchospasm, and they may precipitate the asthma. Now there are few newer drugs that are for sinus tachycardia. Ivabradine is there, and Ivabradine is the newer drug that is approved, और इसको हम नाम से याद करेंगे. First of all is Ivabradine. Brad मतलब bradycardia, so it will be causing bradycardia. VA, that is the side effect, that it can cause visual acuity. Then I, it acts on the eye funny channels, IF channels, that is a funny sodium channel blocker. So Ivabradine is acts on IF channels or I funny sodium channel. It blocks the IF channels. Its side effect is visual acuity, and it can cause bradycardia. I am sorry. And the drugs for AV block is, the definitive treatment of the AV block is permanent implantation of cardiac pacemakers. Then atropine ka, when AV block is due to overactivation of vagal stimulation, then you will be using atropine. When your AV block is due to the overactivation of the vagal stimulation, then atropine doge. Then sympathomimetics, adrenaline, isoprenaline, overcome partial heart block and to maintain the idioventricular rate. So sympathomimetics like adrenaline and isoprenaline, because they overcome the partial heart block and they maintain the idioventricular rate. Then how to select the anti-arrhythmic drug therapy. So basically everything depends upon ECG and your diagnosis. So you will be first of all analyzing the ECG. Then if you found any abnormality, then you will be diagnosing the mechanism of action, and you will be we will come to an diagnosis कि उसका क्या mechanism of action, and फिर आप discuss करोगे drugs की. So जो भी mechanism arrhythmia cause कर रहा है, if you will be having some drugs to block that mechanism, वो आप drug दोगे, and thus you will be analyzing the pharmacokinetics of the drug as well, and then आप hemodynamic effects को analyze करके आप drug दे सकते हो, right? So this is the proper mechanism. Then choice of antiarrhythmic drug कैसे करोगे? तो if there is a atrial extrasystole, and if it is asymptomatic, then no drug is needed as such. But if it is symptomatic, then you will be giving propranolol, because we want to depress that thing, ectopic focus. Then PSVT की अगर मैं बात करूँ, then termination के लिए IV adrenaline is the and prophylaxis के लिए oral verapamil, diltiazem, propranolol and sotalol. But drug of choice is adenosine, right? Then atrial fibrillation के लिए and if we want to reverse the thing to the sinus rhythm, normal sinus rhythm, then you will be doing cardioversion, IV amiodarone, catheter ablation. And ventricular rate control अगर आपको करना है, then आप digoxin दोगे, or you can give verapamil and propranolol as well. Atrial flutter के केस में if you want to reverse it to the sinus rhythm, then cardioversion करोगे, propafenone, verapamil and propranolol. If there is a Wolff-Parkinson-White syndrome or tachyarrhythmia, then propafenone. If you are seeing narrow QRS on ECG, and propafenone plus verapamil if you are seeing wide QRS complex on ECG. Then acute MI के case में, if there is post-MI arrhythmia and if there is bradycardia or bradyarrhythmia, then atropine is the drug of choice. And if there is a ventricular tachyarrhythmia, then IV lidocaine, procainamide, amiodarone and cardioversion. Chronic ventricular tachycardia के केस में propranolol plus amiodarone IV is given, cardioversion and lidocaine. Ventricular fibrillation अगर है, then defibrillation and amiodarone IV. Prophylactically you have to give amiodarone or propranolol orally. Now comes the anti-anginal drugs. So angina pectoris is the pain that arises from the chest due to the increased oxygen demand and decreased oxygen supply, right, in the myocardium. So it is a radiating type of pain. It radiates from the chest and it goes to the left arm, left jaw or left side of the jaw and back, right? And with the pain, patient feels palpitations, patient feels sweating, tremors and all of that. So there is a classical type of angina. The classical type of angina is the common form, and the attacks are predictably evoked or provoked by exercise, emotions, eating or coitus, जिसके अंदर भी sympathetic activity बढ़ेगी, oxygen demand बढ़ेगी, but we cannot supply the good amount of oxygen. तो तभी oxygen की deficiency की वजह से there will be angina. That is a stable angina. और हमें पता होता है कि अगर ये पेशेंट अगर 1 मंजिल 2 मंजिल चढ़ के जाएगा स्टेयर से, देन एंजाइना हो सकता है. सो वी विल बी रेफरिंग हिम कि डिक्रीज योर एक्टिविटी, फिजिकल एक्टिविटी, राइट. सो धीरे धीरे काम करो, राइट. Then the underlying pathology is severe atherosclerotic affliction of larger coronary arteries which run epicardially and send perforating branches to supply the deeper tissues. The coronary obstruction is fixed. Blood flow fails to increase during the increased demand. So that's why there is a pain, right? And ischemic pain is felt. And अगर हमने ट्रीटमेंट, emergency ट्रीटमेंट नहीं दिया, then there will be ischemia, there will be infarction, and yeah, due to inadequacy of ischemic left ventricle, the end diastolic volume or the end diastolic left ventricular pressure rises from 5 to about 25 mm of Hg, produces a subendocardial crunch during diastole. And blood flow to the subendocardial region occurs only during diastole, and it aggravates the ischemia in this region. Thus, a form of acutely developing and rapidly reversible left ventricular failure results, which is relieved by taking rest and reducing the myocardial workload, or by taking the drugs that will be dilating the vessels like GTN sublingually. Drugs that are useful and primarily reduce the cardiac work, that directly act on the heart and indirectly by reducing the preload and hence end diastolic pressure and afterload, they may also cause a favorable redistribution of blood flow to the ischemic areas. Right. Then the most important type is vasospastic, variant or prismental type of angina. It is an uncommon form of angina. It can be, or the prismental attack can also take place during rest as well, or during sleep as well, and they are unpredictable. Like the classical angina was predictable, but this is unpredictable. They are due to recurrent, localized, occasionally diffuse coronary vasospasms, and which may be superimposed on the arteriosclerotic coronary artery disease. Abnormally reactive and hypertrophied segments in the coronary arteries have been demonstrated, and the drugs are aimed at preventing and relieving the coronary vasospasms. Right. So here we will be giving the drugs that will be dilating, right, the arteries. बट जो क्लासिकल एंजाइना में है हम वहां पर लोड डिक्रीज करेंगे, प्री एंड आफ्टर लोड्स. राइट. देन unstable angina with the rapid increase in duration and severity of the attack is mostly due to the rupture of an erythromatous plaque attracting the platelet deposition and progressive occlusion of the coronary artery, occasionally with associated coronary vasospasm. Chronically reduced blood supply causes atrophy of the cardiac muscle with fibrous replacement during the myocardial work capacity that is reduced. Right. So there will be CHF, and they may damage the conducting tissue to produce unstable cardiac rhythms. And anti-anginal drugs relieve the cardiac ischemia but do not alter the course of coronary artery pathology, and no permanent benefit is afforded. And on the other hand, aspirin, ACE inhibitors and statins can modify the coronary artery disease and improve its prognosis. And then we have already discussed about these three types. First of all, stable angina, that is due to ischemia when there is increased demand of oxygen during exercise, exertion and all of that. So हमारे को क्या करना होता है यहाँ पर, aim of the treatment is to decrease the workload on heart, pre और after load decrease करना है. And the second type है unstable, our aim of the treatment is to decrease the work on the heart, same as stable. But variant or prismental or vasospastic के अंदर our aim of the treatment is to dilate the coronary artery, and thus this is the only type of angina that can be caused even at rest. And the drugs that we are having is, so the drugs that we are having are first nitrates, second calcium channel blockers, then beta blockers, then potassium channel blockers. So these are 4 potassium channel openers. So there are 4 types of drugs that we will be discussing about. First of all, nitrates. So these are the preferred emergency drugs that the patient can take himself, right, sublingually. So nitrates अगर हम देते हैं, then it is nitrates get metabolized to NO or nitric oxide, and it stimulates the guanylate cyclase enzyme, which help in the formation of increasing the CGMP, which activates the protein kinase G and inhibits the action of myosin light chain kinase, and thus it causes vasodilation. Right. So nitrates are metabolized to form NO. They stimulates the guanylate cyclase enzyme, which help in the formation of the CGMP, and which acts or which activates the protein kinase G and inhibits the action of myosin light chain, and thus it causes the vasodilation. And this is the mechanism that you have to remember. It can be asked in your vivas, university exams, plus your MCQs as well. And we will be doing MCQ session either tomorrow or day after tomorrow, right? And nitrates. So nitrates के बारे में हम already discuss कर चुके हैं. So they decrease the preload, right? And the most prominent action exerted on the vascular smooth muscle. And nitrate dilate veins more than the arteries, so there will be peripheral pooling of the blood and decreased venous return. That is, the preload will be decreased and the end diastolic size and pressure are reduced. So there will be decreased cardiac work according to the Laplace relationship, which describes the effectiveness of the ventricular wall tension in elevating the intraventricular pressure and the extent to which fiber shortening results into the systolic ejection. Then wall tension is then देखो ये चीज समझने की है. Wall tension is equal to intraventricular pressure into ventricular radius. So when their pressure is decreased, ventricular radius will be decreased, so wall tension will be decreased. So thus reduction of the ventricular radius decreases the tension that must be generated into the ventricular wall, hence decreased O2 consumption is there, right? Decreased O2 consumption is there. And then reduction in cardiac output occurs at rest but is less marked during angina due to the better ventricular emptying. The decrease in the end diastolic pressure abolishes the subendocardial crunch by restoring the pressure gradient across the ventricular wall, due to which the subendocardial perfusion occurs during diastole. It is through their action on the peripheral veins that nitrates exert major beneficial effects in classical angina. So that is the important thing, right? And till now we have discussed the preload reduction. Now we are going to discuss the afterload reduction. So nitrates also produce some arteriolar dilation and slightly decrease the total peripheral resistance or afterload on the heart, and BP falls somewhat, and systolic more than diastolic, and there is reflex sympathetic activity that tends to maintain the diastolic BP. This action contributes to the reduction in the cardiac work, which is directly proportional to aortic impedance with usual doses, and if the patient does not stand still, which favors the pooling of the blood in legs, and tachycardia is not prominent with larger doses, and if the mean BP falls significantly, reflex sympathetic stimulation occurs. Reflex sympathetic stimulation occurs, that will be leading to tachycardia, increased cardiac contractility, increased cardiac work, angina may be precipitated, and fainting and cold sweat occurs due to the cerebral ischemia. All of these can be prevented by laying down and raising the foot end, like this situation. This is the foot, this is the head, right? Raising the foot end. Then comes the mechanism of the relief of the angina. So there is a relaxing effect on the larger coronary vessels, and it is principal action of the nitrate benefiting the variant angina by counteracting the coronary spasm. So like I said, that in presmental angina you have to dilate the vessels, dilate the coronary vessels, right? In the classical angina, undoubtedly the primary effect is to reduce the cardiac work by action on the peripheral vasculature. Though increased blood supply to ischemic area may contribute, exercise tolerance of the angina patients is improved because the same amount of exercise causes lesser augmentation of cardiac work. Heart and peripheral blood flow पे क्या effect आता है? Nitrate have no direct stimulant or depressant action on the heart, right? Basically they dilate the vessels, so they dilate cutaneous vessels as well, so over the face or neck, so that causes flushing and redness over the face, and meningeal vessels causing headache, and splankling and renal blood flow decreases to compensate the vasodilation in other areas. Nitrates tend to decongest the lungs by shifting the blood to the systemic circulation. देन अदर स्मूथ मसल्स पे क्या एक्शन आता है, ब्रोंकाई, biliary tract, esophagus are mildly relaxed. Effect on intestine, ureter, uterus is variable and insignificant, but as such, small doses per generally no effect is produced. Then pharmacokinetics. So organic nitrates are lipid soluble, so they are well absorbed, nicely absorbed through buccal mucosa, and thus they are preferred to give it through sublingual route emergencically, right? Because it passes the first pass metabolism, right? So कोई भी प्रॉब्लम नहीं आती है ऐसे. देन इंटेस्टाइन्स एंड स्किन से भी इजीली अब्जॉर्ब हो जाती है. दैट्स वाई ट्रांसडर्मल पैचेस आर ऑल्सो अवेलेबल. बट इंटेस्टाइन से भी जनरली डोंट प्रिस्क्राइब टू गिव दिस बिकॉज देयर इज हाई फर्स्ट पास मेटाबॉलिज्म. सो अगर हमें इमरजेंसी में यूज करनी है, देन इफ द पेशेंट बेसिकली इंटेस्टाइन से स्लो होगा थोड़ा सा, तो एज कंपेयर टू बक्कल म्यूकोजा, प्लस हाई फर्स्ट पास मेटाबॉलिज्म होगा, सो around 90% of the drug will get metabolized, right? So that's why during emergency we try to give it through buccal mucosa or sublingual route. Then it is ingested orally. All except isosorbide nitrate undergo extensive and variable first pass metabolism in liver. They are rapidly denatrated by glutathione reductase and mitochondrial aldehyde dehydrogenase. The partly denatrated metabolites are less active but have longer T half-life. Though nitrates have been traditionally classified into short-acting, long-acting, and it is the rate of absorption from the site of administration and the rate of metabolism that govern the duration of action of the particular nitrate. For example, GT and isosorbide dinitrate are both short-acting from sublingual but longer-acting from oral route. Right, so GTN and isosorbide dinitrate are both short acting from sublingual route, but they are longer acting from oral route. But yeah, at the same time, at the same point of time, first pass metabolism is high. Adverse effects की अगर बात करें, then these are mostly due to vasodilations. Fullness of the head is there, throbbing headache, because जैसे हमने कहा था meningeal vasodilation भी हो जाता है, flushing हो जाती है face में, so redness भी होगा, fullness of head feel होगा, some degree of tolerance develops on the continued use. Then flushing, weakness, sweating, palpitation, dizziness, fainting are mitigated by lying down and erect posture, and alcohol attenuate these symptoms. So whenever you are taking, तो make sure कि पेशेंट लाई डाउन करे, और अगर उसका ये सब सिम्टम्स आ रहे हैं लाइक फ्लशिंग एंड वीकनेस, सो हेड तो नहीं चाहिए, तो फुट एंड वो ऊपर कर ले, राइट? देन methemoglobinemia is also the adverse effect, and it is not significant with the clinical use doses. However, in severe anemia this can cause, and this can further reduce the O2 carrying capacity of the blood. Rashes are rare, though relatively more common with pentaerythritol tetranitrate, right? So GTN free period, this is the main thing about GTN that you must be knowing before you try to practice. So there is a GTN free period that a physician or clinician will be giving a patient to prevent the tolerance. To prevent the tolerance. So GTN is the drug जिसकी टॉलरेंस बहुत ज़्यादा ईजीली हो जाती है और रैपिडली हो जाती है. सो क्लिनिशियन ट्राई टू गिव अ GTN फ्री पीरियड सो दैट टॉलरेंस को वो डिक्रीज कर पाए, राइट? टॉलरेंस ना डेवलप हो, राइट? सो इनिशियली there is GTN का administration, एंड ऑन प्रोलॉन्ग एडमिनिस्ट्रेशन टॉलरेंस हो सकता है और ये इफेक्टिव नहीं हो सकती, राइट. सो हाउ टू प्रिवेंट दिस टॉलरेंस? Let me give you an example of a transdermal patch. There is a old patient जिसने GTN का transdermal patch लगा रखा है आर्म पर, right? So it is prescribed that before sleeping you have to remove that transdermal patch, and after waking up you have to reapply that transdermal patch. Why this is so? Why this thing is prescribed? Because during sleep, during night, there will be 6 to 8 hours जब हमारी बॉडी में एक्टिवली GTN नहीं जा रही होगी, एंड thus उसका टॉलरेंस नहीं होगा, राइट. एंड दिस इज नीडेड इवन ओरली भी. Even orally we try to keep GTN free period. Interactions. So guys, you should not combine sildenafil with GTN because they can dangerously potentiate to severe hypotension, and there can be severe hypotension, even MI or death. Because sildenafil itself causes hypotension, GTN भी hypotension, severe hypotension. And this thing I will be discussing in further slides. So here nitrate is converted to NO, more in veins, so veno dilation करेगा. Glycerol nitrate is activated by mitochondrial aldehyde dehydrogenase, but all other nitrates are activated by cytoplasmic aldehyde dehydrogenase. Only GTN is there जो activate होती है mitochondrial aldehyde dehydrogenase से. Then mechanism of action needed in classical angina is to decrease the preload. But mechanism of action needed in the variant angina is dilation of the coronary arteries, because we want to decrease the vasospasm. Then drugs. Drugs GTN है, nitroglycerate है, isosorbide dinitrate, isosorbide mononitrate है, penta-erythritol, tetranitrate है, then amyl nitrate है. And the longest name penta-erythritol tetranitrate का है, so that is longest acting drug. Amyl nitrate is shortest acting drug. Shortest name, shortest acting, longest name, longest acting. Then GTN or nitroglycerine or glycerate or isosorbide dinitrate is the drug of choice for acute attack of angina and through sublingual route, and as they are having high first pass metabolism. And IMN mononitrate has minimum first pass metabolism, and longest acting is PETN and the shortest acting is amyl nitrate. Then nitrate free period. If nitrates are continuously administered, then rapid tolerance can take place. To avoid the tolerance, there should be 6 to 8 hours of nitrate free period. Even if you are giving it orally or transdermal patch, there should be 6 to 8 hours of nitrate free period. Then now comes the interaction of the GTN with sildenafil. So guys, nitrate or GTN is converted to NO, then it increases the CGMP, then it causes the vasodilation. But जो CGMP है, अगर उसका amount बढ़ेगी, then there is phosphodiesterase जो कि degrade कर देगा CGMP को, right? So further vasodilation नहीं होगी, right? But if you are giving it with sildenafil, then sildenafil will be inhibiting the phosphodiesterase. सो CGMP जो पहले डिग्रेड हो रहा था वो नहीं होगा, CGMP की क्वांटिटी बढ़ जाएगी. CGMP की क्वांटिटी बढ़ गई तो वेजोडाइलेशन बढ़ जाएगा, पेरिफेरल पूलिंग बढ़ जाएगा, हाइपोटेंशन बढ़ जाएगा, एंड पेशेंट कैन गो इनटू सीवियर हाइपोटेंशन, right? So sildenafil increases the CGMP and thus can cause severe vasodilation and can cause severe hypotension. So nitrate should not be given with sildenafil or combined with sildenafil. Then indications of nitrates, there are many indications. First is angina, classical, presmental, both. But if someone asks you that what is the aim in classical, then you have to decrease the preload, and if someone asks you the aim in presmental or variant angina or vasospastic angina, then dilation of the coronary artery, right? B, say biliary colic, then cyanide poisoning, but drug of choice for cyanide poisoning is hydroxycobalamin. Then MI, myocardial infarction, esophageal spasm, and CHF. These are all indications of the nitrates. Then calcium channel blockers. So these are the L-type calcium channel blockers. First is verapamil, diltiazem, and DHPs, dihydropyridines. First is nifedipine, amlodipine, nicardipine, clevidipine. So DHPs should be avoided in angina as they can increase the heart rate, and drugs like nifedipine, clevidipine can cause severe increase in HR and can precipitate angina. So they should be avoided, right? They are avoided because we don't want to precipitate angina. But long acting DHPs like nicardipine and amlodipine, they can cause vasodilation more than tachycardia, so that's why they are useful in angina. And drug of choice for variant angina की अगर मैं बात करूँ, then variant angina की drug of choice is calcium channel blockers, right? As they dilate the coronary artery. बट वहीं पर जो शॉर्ट एक्टिंग DHPs थे, दे आर कॉन्ट्रा इंडिकेटेड इन द क्लासिकल एंजाइना. एंड एडवर्स इफेक्ट्स की बात करूं, देन हेडेक, कॉन्स्टिपेशन एंड गम हाइपरट्रोफी, राइट? थर्ड, पोटेशियम चैनल ओपनर, निकोरांडिल. So nicorandil is the newer drug that opens the potassium channel and they release NO, so thus they can cause vasodilation. Fourth, we are having beta blockers. Beta blockers, they decrease the HR, they decrease the work, and thus they are useful in classical angina, but they are contraindicated in variant angina. So beta blockers are contraindicated in variant angina, right? अब वेरिएंट एंजाइना में क्यों कॉन्ट्राइंडिकेटेड है? वाई? बिकॉज बीटा 2 इज देयर दैट कॉजेज वेजोडाइलेशन, एंड इफ वी विल बी गिविंग बीटा ब्लॉकर, देन बीटा 2 का एक्शन ब्लॉक हो जाएगा, जो वेजोडाइलेशन कॉज करा था वो ब्लॉक हो जाएगा, एंड दस दिस ब्लॉकेज ऑफ vasodilatory action of beta 2 due to the administration of beta blockers, variant angina precipitate हो जाएगा. Thus beta blockers are contraindicated in variant angina. Then comes the treatment of MI. So guys, initially there is pain जब oxygen demand बढ़ी, and if you will be not giving any emergency treatment, then patient might have ischemia, ischemic pain. That is still reversible, but if तब भी treatment नहीं मिला, then patient might end up in MI, myocardial infarction. That is a irreversible condition, but yeah, still it is having a 6-hour window period, right? So still हम उसको थोड़ा सा तो properly तो नहीं, but yeah, we can reverse the things, but yeah, अगर उसके बाद आए then it is irreversible. Then there are of two types, ST elevation MI, non-ST elevation MI. So non-ST MI के अंदर the drugs are Mona, morphine, oxygen, nitrate and aspirin. And STMI के अंदर as S लग गया, so S मोना, streptokinase, morphine, oxygen, nitrates, and aspirin. So these are the treatment guideline. And now comes the digoxin, the versatile drug. So digoxin is the versatile drug. And wait a second. So digoxin is a cardiac glycoside. It is a versatile drug and it is the only drug under digitalis group, right? And it is the only cardiac glycoside that is used. So there are many type of cardiac glycosides that are present in various things. So heart पर क्या effect आता है वही discuss करते हैं. Digitalis has direct effect on myocardial contractility, electrophysiological properties, and in addition it has a vagomimetic action. Then reflex effects due to the alteration of hemodynamics and direct CNS effects altering the sympathetic activity. Then increase the force of contraction. Digitalis causes a dose dependent increase in the force of contraction of heart. So this is a positive inotropic action. This is especially seen in the failing heart, which is exquisitely sensitive. This is increased velocity or tension of the dependent and higher peak tension can be generated, and systole is shortened and diastole is prolonged. And when a normal heart is subjected to the increased impedance to outflow, it generates an increased tension so that stroke volume is maintained up to a considerable higher values of impedance, while the failing heart is not able to do so and the stroke volume progressively decreases. The digitalized failing heart regains some of its capacity to contract more forcefully when subjected to increased resistance to ejection. There is more complete emptying of failing and dilated ventricles. Then cardiac output is increased and end diastolic volume is reduced. However, therapeutic doses of digoxin do not increase any resting tension and in myocardial fibers. And heart rate is decreased by digitalis. Bradycardia is more marked in CHF patients because improved circulation and due to the positive inotropic action. And it restores the diminished vagal tone and abolishes the sympathetic overactivity. In addition, digitalis slows the heart by vagal and extravagal actions. And vagal tone is increased reflexly by sensitization of the baroreceptor as well as the stimulation of the vagal center. Extravagal की अगर मैं बात करूँ तो extravagal A direct depressant action on SA and AV nodes are seen, and this component of the bradycardia is not reversed by atropine. So this is the mechanism of action of digoxin. So digitalis or digoxin inhibits the NAK ATPase. So this is the main thing जो ये block कर रहा है NAK ATPase pump. So पहले नॉर्मल फंक्शनिंग बताता हूँ आपको. क्या होता है कि अंदर से Na plus goes outside and with exchanging it to the K plus. So Na goes outside, K plus comes inside, right? So what is happening here, Na बाहर चला गया तो Na की क्वांटिटी अंदर कम हो गई. So intracellularly or intracellular environment will be deficient of Na. So there is another channel that is sodium calcium exchanger. So when there is deficiency of sodium, so more amount of sodium comes from outside to inside and calcium goes in outside from inside, right? So as there is already deficiency of sodium, तो इसको पता चल गया तो बाहर से सोडियम तो अंदर आएगा बट अंदर से कैल्शियम बाहर जाएगा बिकॉज दिस इज अ एक्सचेंजर, राइट. सो सोडियम की क्वांटिटी बाहर नॉर्मल हो गई और अंदर भी नॉर्मल हो गई और कैल्शियम बाहर चला गया. अब क्या कर रहा है ये नाउ, अब हमने दे दी डिगॉक्सिन विल बी ब्लॉकिंग दिस थिंग. सो पहले जो सोडियम का डेफिशिएंसी हो रही थी वो अब नहीं हो पाएगी, राइट. सोडियम की डेफिशिएंसी अगर नहीं हो पाएगी देन व्हाट विल हैपन, सोडियम की डेफिशिएंसी नहीं हुई तो बाहर से सोडियम अंदर कैसे आ सकता है और अंदर से कैल्शियम बाहर कैसे जा सकता है? सो ये चैनल भी ब्लॉक हो जाएगा. सो इनिशियली इट विल बी ब्लॉकिंग द NAK ATPase pump, but indirectly it will be blocking the sodium calcium exchanger as well, right? So ये ब्लॉक हो गया. अब क्या हो रहा है, जो अंदर कैल्शियम इकट्ठा हो रहा है वो बाहर नहीं जा पा रहा, तो अंदर कैल्शियम एक्यूमुलेट होता जाएगा होता जाएगा होता जाएगा, राइट? सो देयर इज अ कैल्शियम चैनल एज वेल. सो वहां से कैल्शियम अंदर आएगा. जब भी एक्शन पोटेंशियल या स्टिमुलस आया तो वो कैल्शियम अंदर आया, कैल्शियम साइटोप्लाज्म में आया, राइट? और फिर वो जाएगा सर्का के अंदर और एंडोप्लाज्मिक रेटिकुलम के अंदर. एंडोप्लाज्मिक रेटिकुलम के अंदर गया तो कैल्शियम वहां जाकर कॉन्ट्रैक्टिलिटी बढ़ाएगा. सो यहाँ एक बहुत इंपॉर्टेंट चीज है कि जो भी आपका कैल्शियम साइटोप्लाज्म में पड़ा है वो कॉन्ट्रैक्टिलिटी नहीं बढ़ा सकता, राइट? जो भी कैल्शियम आपका एंडोप्लाज्मिक रेटिकुलम में है सिर्फ वही कॉन्ट्रैक्टिलिटी बढ़ा सकता है, राइट? सो कैल्शियम और साइटोप्लाज्म के अंदर भी एक सस्टेन्ड अमाउंट ऑफ कैल्शियम ही रह सकता है, राइट? सो बी इट 100 molecules of calcium, so only 100 ions ही रह सकते हैं कैल्शियम के साइटोप्लाज्म में. फिर कहाँ जाएंगे? बाहर तो जा नहीं पा रहे, तो उसके ऊपर जितने भी कैल्शियम के आयंस इकट्ठे होते जा रहे हैं, एक्यूमुलेट होते जा रहे हैं, वो सब एंडोप्लाज्मिक रेटिकुलम में जाएंगे. और एंडोप्लाज्मिक रेटिकुलम में जाने के बाद वो कॉन्ट्रैक्टिलिटी बढ़ाएंगे, राइट? एंड दस कॉन्ट्रैक्टिलिटी बढ़ाने के, अब कॉन्ट्रैक्टिलिटी जो ये बढ़ाता है डिगॉक्सिन, वो एक स्लो प्रोसेस है. उसके लिए एक थेरेपी की जरूरत है. फर्स्ट डोज इफेक्ट नहीं काम कर सकता, राइट? डिगॉक्सिन की एक डोज कैन नॉट इंक्रीज कॉन्ट्रैक्टिलिटी. वी नीड मेनी डोजेस if we want to increase contractility, because this process is really slow, and digitalis do not increase heart rate, it only increases the contractility. That's why it is indicated in CHF as well. Then electrophysiological changes की अगर मैं बात करूँ, then action potential पर the resting membrane potential is progressively decreased with the increasing doses, and excitability is enhanced at low doses but depressed at toxic doses because Na plus channels are inactivated. The rate of phase 0 depolarization is reduced, resulting in slowing of conduction, and this action is more marked in AV node and bundle of His. The slope of phase 4 depolarization is increased in the PFs. Ectopic automaticity is enhanced. The latent pacemakers become overt at high doses, producing extrasystoles. Then high doses of digitalis produce coupled beats by another mechanism. The RMP shows oscillations during phase 4 when their magnitude is sufficient enough. Delayed after depolarizations result. And the SA and the AV node automaticity is reduced at therapeutic concentrations by vagal action, which hyperpolarizes these cells and reduces the phase 4 slope. So thus toxic doses markedly reduce RMP of SA node cells by direct action and stop impulse generation. The action potential duration is reduced and the amplitude of the action potential is also diminishes. Then conduction की अगर मैं बात करूँ, then AV conduction is demonstrably slowed by therapeutic doses, and this is the main mechanism जिसकी वजह से हम इसको एंटी अरिथमिक में यूज करते हैं. At high doses, intervention or intraventricular conduction in PFs is also depressed by uncoupling of the gap junctions. ECG में क्या changes आते हैं? Therapeutic doses of digitalis produces changes in ECG. These are attenuated at high doses and may also produce arrhythmias. Then decreased amplitude or inversion of T wave, then increased PR interval, due to slowing of the AV conduction, then AV block at toxic doses, shortening of the QT interval, and depression of the ST segment at high doses due to the interference of the repolarization. And blood vessels, digitalis has mild direct vasoconstrictor action. Peripheral resistance is increased in normal individuals. However, in CHF patients, this is more marked or more than compensated by the indirect effect of improvement in circulation. That is, reflex sympathetic overactivity is withdrawn and a neck decrease in peripheral resistance occurs. So digitalis has no prominent effect on BP. Systolic BP may increase and diastolic may fall in CHF patients. Pulse pressure increases. And hypertension is no contraindication to the use of digitalis. And therapeutic doses of digitalis have no significant effect on coronary circulation. Coronary insufficiency is no contraindications to its use. Right. And then on kidney, diuresis occurs promptly in CHF patients, secondary to improvement in circulation and renal perfusion. The retained salt and water is gradually excreted, and no diuresis occurs in normal individuals or in patients with edema due to other causes. CNS की अगर मैं बात करूँ तो digitalis has little apparent CNS effects in therapeutic doses. Higher doses cause CTZ activation, nausea and vomiting. Still, higher doses produce hyperapnea, central sympathetic stimulation, mental confusion, disorientation and visual disturbances. And pharmacokinetics की बात करें तो bioavailability of the digoxin tablets from different manufacturers may differ, and presence of the food in stomach delays the absorption of digoxin. So basically, empty stomach is rather effective. The volume of distribution of digoxin is large, 6 to 8 liters per kg. It is contraindicated in heart. It is what I am saying. It is concentrated in the heart 20 times more than plasma, skeletal muscle, liver and kidney. Right. So digoxin is concentrated in the heart 20 times more than plasma. And its vagomimetic effect is the effect that is useful in arrhythmia or anti-arrhythmic action, right? Because of its parasympathetic increment or because of its decreased heart rate, decreased conduction, so it is useful in atrial fibrillation. And thus heart rate जब इतना ज़्यादा है 400 to 500 beats per minute, then it can convert into ventricular fibrillation. So atrial fibrillation can convert it to ventricular fibrillation, and we want to prevent this conversion, this transmission. So we will be providing digoxin, right? So aim of the treatment here is to decrease the ventricular rate during or in the patient of atrial fibrillation, and thus digitalis is there that will be decreasing the conduction from the atrium to the ventricles, right? Then there were two drugs under the group digitalis. One was digoxin, other was digitoxin. Digoxin was the drug that was mainly excreted by kidney, and digitoxin was mainly metabolized by the liver. So digoxin was contraindicated in the renal failure and digitoxin was contraindicated in the liver failure. But digitoxin is withdrawn now because it causes a high potency of hepatotoxicity even at lower doses. Digoxin is the only inotropic drug that can be given orally, and adverse effects are nausea, vomiting, arrhythmia, gynecomastia, xanthopsia, yellow vision. Most common arrhythmia that can be caused by digoxin is ventricular bigeminy. This is the main question of MCQ, that which is the most common arrhythmia that digoxin or digitalis drug can cause. That is ventricular bigeminy, right? So digitalis toxicity की अगर हम बात करें, then factors increasing the digitalis toxicity is first is metabolic disorders जो कि predispose करते हैं, that is increased calcium, decreased potassium and decreased Mg2+. So guys, it is believed that जो potassium है ना वो उसी जगह एक्ट करता है जहां पर डिगॉक्सिन एक्ट करती है. So, अगर पोटेशियम कम होगा तो डिगॉक्सिन ज्यादा एक्ट करेगी, और अगर पोटेशियम ज्यादा होगा देन डिगॉक्सिन कम एक्ट करेगी. सो समटाइम्स फॉर द ट्रीटमेंट ऑफ द डिजिटालिस टॉक्सिसिटी वी ट्राई टू गिव K+ from outside, right? And the other drugs that can cause or that can predispose to the digitalis toxicity is quinidine, verapamil, amiodarone and thiazides. So these are the drugs that can cause toxicity, plus pathological condition if patient is having a renal failure or liver failure then also. So मैंने मेटाबॉलिक तो आपको समझा दिया K+ के साथ. सो K+, इट इज बिलीव्ड दैट K+ का जो रिसेप्टर है वहीं पर डिगॉक्सिन एक्ट करती है. जब K और सेम एक तरीके से व्हाट इज दैट कॉल्ड, एक्टिव साइट. हाँ, सो सेम एक्टिव साइट पर एक्ट करती है डिगॉक्सिन भी और K भी, राइट, K+ आयन भी. सो व्हेन देयर इज deficiency of K, so digoxin ज़्यादा एक्ट करेगी, और when there is more of K, so digoxin कम एक्ट करेगी, right? So during the digoxin toxicity we try to provide K+ from outside, but before that हमें मॉनिटर करना पड़ता है कि K+ कहीं नॉर्मल तो नहीं है. अगर वो नॉर्मल होंगे और हम आगे बढ़ा देंगे तो प्रॉब्लम हो सकती है. देन ट्रीटमेंट ऑफ डिजिटालिस टॉक्सिसिटी. So treatment of digitalis toxicity is for correction of the cause. Drug of choice for digitalis induced arrhythmias, lignocaine, phenytoin. Digibind for severe poisoning. Then monoclonal antibody against digitalis. So treatment of digitalis induced toxicity is to correct the cause first of all, right? First of all diagnose the cause जिसकी वजह से cause कर रही है digitalis toxicity. Then correct that, और अगर arrhythmia है then treat it with lignocaine, phenytoin. अगर तब भी ठीक नहीं हुआ then give a monoclonal antibody, digibind to the patient, right? Which doctor give digoxin induced arrhythmia? The notification of a length of which drug to give in digoxin induced arrhythmia. So digoxin induced arrhythmia के अंदर you have to give lignocaine and phenytoin, like I have said earlier. Therapeutic index is just 1.5 to 3, so it is having a low therapeutic index, right? Range is low. So there are various cardiac and extracardiac effects. So initially extracardiac effects are anorexia, nausea, vomiting, abdominal pain. They are reported first, and they are due to the gastric irritation, mesenteric vasoconstriction, CTZ stimulation. Then there can be fatigue, malaise, headache, mental confusion, restlessness, hyperapnea, disorientation, psychosis, visual disturbances. They are other complaints. Then skin rashes, gynecomastia are rare, but yeah, it can produce it. Cardiac effects, almost every type of arrhythmia can be produced by digitalis. For example, pulsus bigemini or ventricular bigemini is the most common arrhythmia. Nodal and ventricular extrasystole, ventricular tachycardia, and terminally ventricular fibrillation it can cause. Then partial to complete AV block may be the sole cardiac toxicity, or it may accompany other arrhythmias as well. Severe bradycardia, atrial extrasystoles, AF, AFIs have also been noted, and in about two-thirds of the patient showing toxicity, extracardiac symptom precede the cardiac. In the rest, serious cardiac arrhythmias are first manifestations. But इससे अब आगे बढ़ने से पहले मैं ये बताना चाहता हूँ कि guys, hormones or drugs affecting the endocrine system और hormonal drugs का कोर्स स्टार्ट हुआ है on Unacademy app, right? So this is my first plus course जो अभी चल रहा है. 15th से स्टार्ट हुआ था, 15th से 23rd तक चलेगा. 8 सेशंस होंगे, एंड जो 9th सेशन होगा वो क्विज होगी. राइट. सो दैट इज ऑन द प्लस कोर्स. राइट. सो अगर आपके पास सब्सक्रिप्शन है देन आपको बेनिफिट हो जाएगा. ठीक है. तो ड्रग्स अफेक्टिंग एंडोक्राइन सिस्टम चल रहा है अनअकैडमी की ऐप पर एंड इट इज़ अ प्लस कोर्स और 23rd को क्विज होगी. सो इफ़ यू आर इंटरेस्टेड देन यू कैन कम एवरी डे 8 PM. सो टिल 23rd ऑब्वियसली. सो 15th से स्टार्ट हुआ था. 8 PM रोज एक क्लास होती है 60 मिनट्स की. कभी हम एक्सटेंड भी कर देते हैं. सो लाइव होता है. So you are most welcome guys, you can come. And treatment of the adverse effects की अगर मैं बात करूँ for tachyarrhythmias when caused by the chronic use of digitalis and diuretics influence the KCL because like I said कि K+ की quantity decrease होने की वजह से भी हो सकता है. तो K+ को सबसे पहले हमें increase करना है. So administer or infuse K+ और KCL. Right. And higher extracellular K+ decreases binding of the glycoside to the NAK ATPase pump by favoring a conformation of the enzyme that has lower affinity for the glycoside. And K+ tends to antagonize the digitalis induced enhanced automaticity. So when toxicity is due to the acute ingestion of the large doses of digoxin, so then plasma K+ may be high. And it should not be given from outside in the cases when it is desirable to measure the serum K+ to guide the KCL therapy. K+ is contraindicated when there is a high degree of AV block. So AV block के case में K+ is contraindicated, and because complete AV block and ventricular asystole may be precipitated. Then for ventricular arrhythmias, lidocaine AV repeated as required is the drug of choice. It suppresses the excessive automaticity but does not attenuate AV block. Then quinidine, procainamide and propafenone are contraindicated. For supraventricular arrhythmias, propafenone may be given IV and orally depending upon the urgency. For AV block and bradycardia, atropine 6 to 1.2 mg IM may help, otherwise cardiac pacing is recommended. Uses इसके काफ़ी सारे हैं. First of all is congestive heart failure. CHF occurs when cardiac output is insufficient. So when we want to increase the inotropicity, and yeah, our aim of the treatment to treat CHF is to increase the inotropicity and thus digoxin is preferred. Right. And current status of digitalis before the introduction of high ceiling diuretics, ACE inhibitors, beta blocker, digitalis was considered an indispensable part of anti-CHF treatment, but now it is not considered such as like earlier. Many mild to moderate cases are managed without even digoxin, and now ACE inhibitors, ARBs, beta blockers and diuretics are standard treatment. However, digitalis is still the most effective drug applicable of relieving the symptoms of CHF and restoring the cardiac compensation, especially in the patients with dilated heart and low ejection fraction. All the patients who remain symptomatic even while receiving the ACE inhibitors or ARBs, beta blocker and diuretic should be treated with digitalis. Uncertainty exists in the area of maintenance therapy, that is after decompensation has been corrected in the patient with sinus rhythm and not having atrial fibrillation. Thus, if stable clinical state has been maintained 2 to 3 months, withdrawal of the digitalis may be attempted. Early reinstitution of digitalis is recommended for the cardiac if cardiac status declines, and continued digitalis therapy is the best course in the CHF patients with atrial fibrillation who need a ventricular rate control. And then it is useful in cardiac arrhythmias, और कहाँ use होता है we have already discussed. And then comes antihypertensive drugs. So this we have already discussed. We have talked about hypertension. Hypertension is the lateral pressure जो कि आपकी blood vessel को feel होता है, right? So hypertension is also known as a high or raised blood pressure, but hypertension is a serious medical condition and can increase the risk of heart, brain and target organ damage basically, right? End organ damage, right? So that's why we have to decrease the BP. So it is the lateral pressure exerted by the moving column, or lateral pressure that is exerted on the blood vessel or wall of the blood vessel. And the drugs by which we can reduce the BP, first is diuretics, then vasodilators, sympathetic system blockers, RAS blockers, right? And diuretics की अगर मैं बात करूँ, then loop and thiazide. Loop diuretics are useful in CHF, but thiazides are useful in hypertension. Hypertension are weak but longest acting, so that's why they are prescribed, and they are used as first line drug for HTN. Vasodilators की अगर मैं बात करूँ, then NO release जो करते हैं, that is sodium nitroprusside and hydralazine. They both are fast acting, and hypertensive emergencies में they are useful. And sodium nitroprusside की अगर मैं बात करूँ, then NO release करता है in both arteries and veins. That's why it can dilate both arteries and veins. Plus there is a micro drip set that is used, which is having 64 drops for 1 ml. अगर आपको पता होगा, क्लिनिक्स में गए होगे तो 1 ml जनरली होता है 8 ड्रॉप्स का और 16 ड्रॉप्स का, बट we can use micro drip set that consists of 64 drops, and it is used. Long term use can lead to cyanide poisoning, and antidote is hydroxycobalamin. Hydralazine की अगर मैं बात करूँ, then metabolized by acetylation, and side effect is SLE, systemic lupus erythematosus. Then we can use L-type calcium channel blockers, verapamil, diltiazem and DHPs, and then we can use potassium channel openers, MDH. So हमने पहले निकोरांडिल की बात करी थी एंजाइना में, बट निकोरांडिल एंजाइना में यूजफुल है, बट यहाँ पर नहीं है. Here we are having minoxidil, diazoxide and hydralazine. So hydralazine is having a vasodilating action plus K plus opening action. मिनॉक्सीडिल का इंडिकेशन एंटी हाइपरटेंसिव से ज़्यादा हेयर ग्रोथ में यूज होता है. इट इज़ यूज्ड फॉर ट्रीटमेंट ऑफ एलोपेशिया, राइट. And diazoxide, they decrease insulin, so that's why it is contraindicated in diabetes mellitus, and it is useful in insulinoma. Then sympathetic system blockers, ganglion blockers, trimethorphan, hexamethonium, mainly used as an antidote for the nicotinic poisoning. Alpha-2 agonists, clonidine, methyl dopa, they are safer in pregnancy, but they can cause dry mouth and sedation. Then alpha and beta blockers, phenoxybenzamine, phentolamine, prazosin, metoprolol, atenolol and carvedilol. RAS inhibitors की अगर मैं बात करूँ, then sympathetic blocker, direct renin inhibitor, ACE inhibitor, ARBs, aldosterons are there. So sympathetic blockers के अंदर beta 1 blocker, aliskiren, ACE inhibitors में captopril, pril वाली drugs, ARBs में sartans, aldosterone के अंदर spironolactone. And then diuretics में thiazides. These are the diuretic of choice for the uncomplicated hypertension and have similar efficacy and are dose to dose equivalent. All mega trials have been carried out with these two only. Chlorthalidone is longer acting than hydrochlorothiazide and may have better round the clock action. Indapamide is used mainly as antihypertensive and is equally effective. There is little experience with the other members of the thiazide class, and they should not be considered interchangeable with hydrochlorothiazide and chlorthalidone as antihypertensive. The proposed mechanism of antihypertensive action is, first of all, is initially the diuresis reduces the plasma and ESF volume by 5 to 15%, and this decreases cardiac output. But subsequently, a compensatory mechanism operates to almost regain the sodium balance and plasma volume, and cardiac output is restored. But the fall in BP is maintained by slowly developing reduction in total peripheral resistance. This is really an important thing. Initially, there is reduced plasma quantity, and the later cases के अंदर there is decreased total peripheral resistance, right. The reduction in the TPR is most probably an indirect consequence of the small persisting sodium and volume deficit. Decrease in the intracellular sodium concentration in the vascular smooth muscle may reduce the stiffness of the vessel wall, increase their compliance, and dampen the responsiveness to the constrictor stimuli. Noradrenaline, angiotensin 2. Similar effects are produced by salt restriction. Antihypertensive action of diuretics is lost when salt intake is high. A mild, slowly developing vasodilator action of thiazide due to the opening of the smooth muscle K plus ATP channels and hyperpolarization has been proposed but does not appear to be real. And the fall in BP develops gradually over 2 to 4 weeks. During long-term treatment with thiazides, the heart rate and cardiac output remain unaffected, while TPR is reduced despite of compensatory increase in plasma renin activity, which confirms persisting Na plus deficit. Thiazides have no effect on capacitance vessels. Sympathetic reflexes are not impaired. Postural hypotension is rare. Thiazides are mild antihypertensives and average fall in mean arterial pressure is equal to 10 mm of Hg. They are effective by themselves in 30% cases, mostly low-grade hypertension. But they potentiate all other hypertensives except DHPs and prevent development of tolerance to other drugs by not allowing expansion of the plasma volume. Thus, in combination, they are useful in any grade of hypertension. They are most effective in elderly. Maximal antihypertensive efficacy is reached at 25 mg per day dose. The higher doses produce greater diuresis, and their antihypertensive action is attenuated by NSAIDs. And high ceiling diuretics की अगर मैं बात करूँ, then furosemide, the prototype of this class, is a strong diuretic, but antihypertensive efficacy is not parallel diuretic potency because furosemide is a weaker antihypertensive drug. Fall in BP is entirely dependent on the reduction in the plasma volume and cardiac output. Right. So ये TPR increase नहीं कर सकता. TPR and vascular responsiveness is not reduced. Moreover, the high ceiling diuretic is more liable to cause fluid and electrolyte imbalance and weakness and other side effects. They are indicated in hypertension only when it is complicated by CHF or renal failure and resistant to the combination regimes containing thiazide or marked fluid retention due to the use of potent vasodilators. And desirable properties of thiazide diuretic as antihypertensives are once a day dosing, flat dose response curves, no fluid retention, no tolerance, low incidence of the postural hypotension, isolated systolic hypertension, lessened risk of hip fracture in elderly due to the hypocalciuric action of thiazides, and low cost. Right, and current status of diuretic as antihypertensive is the popularity of diuretic had ups and downs, but अब वो कम हो चुका है because ACIs आ गए हैं और ARBs भी यूज होने लग गए हैं. And it is having a few drawbacks. It can cause hypokalemia, and due to hypokalemia there can be muscle pain, fatigue, loss of energy. Erectile dysfunction in males, carbohydrate intolerance due to the inhibition of the insulin release, precipitation of diabetes, dyslipidemia, rise in total and LDL cholesterol, and TGs with lowering HDL. This could increase the atherogenic risk, but no direct evidence has been obtained. Hyperuricemia by inhibiting the urate excretion, increased incidence of the gout is seen. Increased incidence of sudden cardiac death is also seen, attributed to episodes of the Torsades de Pointes and ischemic ventricular fibrillation precipitated by hypokalemia. Then potassium sparing diuretics or aldosterone antagonists, spironolactone and eplerenone and amiloride, but not triamterene themselves lower BP slightly. However, they are used in the conjugation with the thiazide to prevent K plus loss and to augment the antihypertensive action. Spironolactone is not favored because of its hormonal side effects, gynecomastia, impotency, and menstrual irregularities. This problem has been offset in the newer aldosterone antagonist eplerenone and is increasingly used. With the recent appreciation of the role of aldosterone in promoting the hypertension-related ventricular and vascular hypertrophy, remodeling renal fibrosis, it is considered that aldosterone antagonists will attenuate these complications. As such, these resurgence in this use, especially in refractory hypertension, hyperkalemia, should be watched when K plus pairing diuretics are used with ACE inhibitors and ARBs. Angiotensin converting enzymes. The ACE inhibitors are one of the first choice drugs in all grades of essential as well as renovascular hypertension. Most patients require relatively low doses, which are well tolerated. Used alone, they control hypertension in 50% of the patients, and addition of a diuretic beta blocker effect extends efficacy to the 90%. Because of the supraadditive synergism, they only a low dose of diuretic, 12.5 mg of hydrochlorothiazide, really 25 mg needs to be added. Their potential to retard diabetic nephropathy and their capacity to regress the left ventricular and vascular hypertrophy, they are the most appropriate antihypertensive in patients with diabetes, nephropathy, even non-diabetic nephropathy, and left ventricular hypertrophy, CHF, angina, and post-MI cases. Dry persistent cough is the most common side effect, requiring the discontinuation of ACE or starting of the ARBs, right? And this is due to the accumulation of the bradykinin. Then ARBs in the dose of 50 mg per day. Losartan is effective antihypertensive, and it manifests early and progresses to the peak at 2 to 4 weeks. Then addition of the 12.5 mg per day hydrochlorothiazide further enhances the fall in BP. The newer ARBs, valsartan, candesartan, irbesartan, telmisartan, have been shown to be effective antihypertensives as ACE inhibitors. While losartan may be somewhat weaker than high doses of ACE inhibitors, ARBs are markedly free of side effects. Because they do not increase kinin levels, the ACE inhibitor related cough is not encountered. Angioedema, urticaria, taste disturbances is also rare. The effect of ACE inhibitors, ARBs, are not identical. The latter have all the metabolic and prognostic advantage of ACE inhibitors. Then DRIs, direct renin inhibitors. Aliskiren is the only available member of the latest class RAS inhibitor, which act by blocking the catalytic activity of renin and inhibit the production of angiotensin 1 and 2. Aliskiren is equally effective as an antihypertensive as ACE inhibitors and ARBs, but experience with it so far is limited. However, no remarkable features have emerged, and presently it is a second-line antihypertensive which may be employed when the more established ACE inhibitors and ARBs cannot be used or to supplement them. Right. And calcium channel blockers, CCBs, are another class of the first-line antihypertensive drugs. So the first-line antihypertensive drugs, all the three groups of the CCPs, DHPs, amlodipine, nicardipine, verapamil, diltiazem, are equally efficacious antihypertensives. They lower BP by decreasing the peripheral resistance without compromising the cardiac output. Despite vasodilation, fluid retention is insignificant. Ankle edema that occurs in some patients is due to the increased hydrostatic pressure across the capillaries of the dependent parts as a result of reflex constriction of post-capillary vessels in these vascular beds. The onset of the antihypertensive action is quick. With the availability of the long-acting preparation, most agents can be administered once a day. Monotherapy is effective in equal to 50% of hypertensives. Their action is independent of the patient's renin status, and they may improve the arterial compliance as well. Then other advantages of the CCPs are they do not compromise any hemodynamic effect, no impairment of the physical work capacity, no sedation, and no other CNS effects. Cerebral perfusion is also maintained, not contraindicated in asthma, angina, and PVD patients. Do not impair renal perfusion, do not affect male sexual function, no deleterious effect in on plasma lipid profile, uric acid levels, electrolyte balance, and shown to have no or minimal effect on quality of life. So that's why it is preferred. No adverse fetal effects can be seen, so that's why it is also used in pregnancy, and nicardipine is the drug that is generally used. Other concerns in the use of CCPs as antihypertensives are the negative inotropic dromotropic action of the verapamil, diltiazem may worsen the CHF and cardiac conduction defects. They, by their smooth muscle relaxant action, the DHPs can worsen the gastroesophageal reflux. CCBs may attenuate bladder voiding difficulty in elderly males. And beta blockers की अगर मैं बात करूँ, they are mild antihypertensives, do not significantly lower the BP. In normotensives used alone, they suffice 30 to 40% of the patients, mostly stage 1 cases. Additional BP lowering may be obtained when combined with other drugs. The hypotensive response to beta blockers develop over 1 to 3 weeks and is then well sustained. Despite short and differing plasma half-lives, the antihypertensive action of the most beta blockers is maintained over 24 hours with a single daily dose. All the beta blockers, irrespective of associated properties, exert similar antihypertensive effect. Drugs with intrinsic sympathomimetic activity cause less or no reduction of HR and cardiac output but lower the vascular resistance by beta 2 agonism. Nevibolol reduces the TPR by generating NO. The non-selective beta blockers slightly reduce the renal blood flow and GFR, but this is minimal in the beta 1 selective beta blockers and in those with ISAs. There are several contraindications to beta blockers, including cardiac, pulmonary, PVD, etc. The non-selective beta blocker have an unfavorable effect on the lipid profile. They raise the TG levels, they raise the LDL levels, and they decrease the HDL levels, and thus we call this condition as dyslipidemia. They have also fared less well on equality of the life parameters like decreased work capacity, fatigue, loss of libido, and supple cognitive effect, forgetfulness, low drive, nightmares, and increased incidence of the antidepressant use. Many of these drawbacks are minimized in beta 1 selective agents and in those which penetrate brain poorly. And patients' acceptability of beta 1 selective hydrophilic drug like atenolol is better than that of propranolol. However, some recent studies have pointed out that atenolol monotherapy may be less effective in preventing the hypertension-related stroke and coronary artery disease because of the absence of the postural hypotension, bowel alteration, salt and water retention, or low incidence of side effect and other once a day regime. Beta blocker retain their place among the first choice of the drug recommended by GNC 7 and 8, especially for relatively young non-obese hypertensives, those prone to psychological stress, or those with ischemic heart disease. Then beta blockers and ACE inhibitors are the most effective drugs for preventing sudden cardiac death in the post-infarction patients. However, they are less effective for primary prophylaxis of MI and for preventing the left ventricular hypertrophy. All the mortality have been lowered in the long-term trials by beta blockers. Hypertensives with stable heart failure should be treated with one of the selected beta blockers, metoprolol, bisoprolol, carvedilol, nevibolol, along with an ACE inhibitors or ARBs. Then rebound hypertension has occurred on sudden discontinuation of beta blocker. Myocardial ischemia may be aggravated, angina or MI may be precipitated. And then beta and alpha adrenergic blockers, newer drugs labetalol and carvedilol. Labetalol, it is having a combined alpha and beta blocking. It reduces the TPR and acts faster than pure beta blocker. It has been used IV for rapid BP reduction in hyperadrenergic states, cheese reaction, clonidine withdrawal, and eclampsia. Oral labetalol therapy is restricted to moderately severe hypertension, not responding to a pure beta blocker, because side effect of both alpha and beta blocker occur with it. This non-selective beta blocker has a weak alpha 1. Carvedilol is a non-selective beta blocker, plus it is having a selective alpha 1 blocking, and it is also having an antioxidant property. So whether these ancillary properties confer any superiority is not known. Carvedilol is frequently selected drug for long-term treatment of CHF and is approved for as antihypertensive as well. Side effects are similar to labetalol. Liver enzymes may rise in some individuals. Then prazosin comes. This is a prototype selective alpha 1 antagonist, dilates both resistant and capacitance vessels. Effect on the former predominating vessels. The hemodynamic effect is with respect to reduction in the TPR, mean BP accompanied minor decrease in the venous return, and cardiac output are similar to that produced by the direct acting vasodilator. Unlike hydralazine, there is little reflex cardiac stimulation and renin release during long-term therapy. And tachycardia does not compensate for the fall in BP because release inhibitory alpha 2 receptors are not blocked and autoregulation of NA release remains intact. It probably decreases certain central sympathetic tone also. Renal blood flow GFR are maintained, but fluid retention may attend fall in BP. Then adverse effects की बात करूँ, then plazosine is generally well tolerated at low doses, but there are high chances of postural hypotension, and particularly in the beginning, first dose effect. And other side effects are headache, drowsiness, dry mouth, weakness, palpitation, nasal blockade, blurred vision, ejaculation may be impaired in males, especially with the higher doses, and fluid retention attending prazosin monotherapy may precipitate CHF. Then prazosin is moderately potent hypertensive medication, but it is not used as a first line drug because of its fluid retention, and tolerance gradually develops with monotherapy, necessitating the dose increase, more side effects and risk of CHF. It may be added to a diuretic or beta blocker in those not achieving the target BP. Then non-selective beta blocker, alpha blocker, phentolamine and phenoxybenzamine. So these are generally not used. Phenoxybenzamine is irreversible, phentolamine is reversible, and phenoxybenzamine is having its use in pheochromocytoma, and phentolamine is useful in cheese reaction, clonidine withdrawal reaction, and all of that, right, in which there are hypertensive crises. Central sympatholytics, clonidine, it is the imidazoline derivative, have complex actions. Clonidine is a partial agonist with high affinity and high intrinsic activity alpha 2 receptors, especially alpha 2A subtype in brainstem. The major hemodynamic effect result from stimulation of the alpha 2A receptor present mainly postjunctionally in the medulla. This decreased sympathetic outflow, fall in BP and bradycardia, enhanced vagal tone contributes to bradycardia, and plasma NA declines. Though clonidine is capable of reducing NA release from peripheral adrenergic nerve endings, release inhibitory post-junctional alpha 2 actions. This is not manifest at clinical doses. So clonidine is moderately potent antihypertensive, but clonidine also activates the imidazoline receptors, which are distinct from the alpha 2 receptors, and they are present in the brain as well as in the periphery. So activation of the medullary imidazoline receptor causes decreased sympathetic outflow and fall in BP. Rapid IV action of clonidine raises the BP transiently due to the activation of the peripheral postsynaptic vasoconstrictor alpha 2B receptor at the higher concentration so attained during IV injection. Oral doses produce lower plasma clonidine levels, cause only fall in BP. Because clonidine has lower intrinsic activity on the alpha 2B receptors, which predominate in the vascular smooth muscles. Probably for the same reason, clonidine exhibits the therapeutic window phenomena. Optimum lowering of the BP occurs between the blood levels of 0.2 to 2 Ng per ml, and at higher concentrations, fall in BP is less marked. And on chronic administration of clonidine, decrease in the cardiac output contributes more to the fall of BP than decrease in the TPR. Cardiovascular reflexes are affected little. Then decreased sympathetic outflow to the kidney results in the reduced renin release, and plasma lipid levels are not altered. Then adverse effects. Side effects with clonidine are relatively common. Sedation, mental depression, disturbed sleep, dryness of mouth, nose, eyes, and secretion is decreased by central action, constipation, anti-secretory effect on the intestines. Impotency, salt and water retention, and bradycardia. Then postural hypotension occurs, but it is mostly asymptomatic. Alarming rise in BP in excess of pre-treatment level with tachycardia, restlessness, anxiety, sweating, headache, nausea, vomiting occur in some patients when doses of clonidine are missed for 1 to 2 days. The syndrome is very similar to that seen in pheochromocytoma. Plasma catecholamine concentration is increased. This is due to the sudden removal of the central sympathetic inhibition, resulting in the increase of larger quantities of the stored CAs. Supersensitivity of the peripheral adrenergic structures of the catecholamine that develops due to the chronic reduction of the sympathetic tone due to the clonidine therapy. So these are the two reasons. A combination of the alpha blocker with the beta blocker or a potent vasodilator or clonidine itself can be used to treat the syndrome. And other indications, opioid withdrawal की अगर मैं बात करूँ, then opioid and alpha 2 adrenergic syndrome converge on the same effector in many systems. Both activate the GI regulatory protein. Clonidine suppresses the sympathetic overactivity of the opioid withdrawal syndrome and reduces the craving of some extent. Clonidine has also facilitated alcohol withdrawal and smoking cessation. Clonidine has analgesic activity. It has been used to substitute morphine for intrathecal, epidural, surgical and post-operative analgesia. Then clonidine attenuates vasomotor symptoms for menopausal syndrome as well. Clonidine has been used to control loose motions for diabetic neuropathy, and it may be acting by alpha 2 receptors and mediated enhancement of the salt reabsorption in the gut mucosa. Then methyl dopa. It is generally same as clonidine, and it is also safe in pregnancy. This alpha methyl analog of dopa, the precursor of dopamine and NA, is one of the first rationally designed antihypertensives. The alpha methyl NA formed in the brain from methyl dopa acts on the central alpha 2 receptor to decrease the afferent sympathetic activity. Because methyl dopa decreases the TPR more than the HR or cardiac output, it may be acting on the different population of the neurons in the vasomotor center than clonidine. In large doses, methyl dopa inhibits the enzyme dopa decarboxylase in the brain and periphery, and it reduces the NA synthesis and forms the false transmitter methyl NA in the periphery, as well as these mechanisms all were considered to be responsible for the antihypertensive effect. But it was demonstrated that neither responses of stimulation of sympathetic nerves nor their NA content was reduced at clinically used antihypertensive doses. Moreover, alpha methyl NA is a potent vasoconstrictor as NA. The primary central site of the action of methyl dopa has been confirmed. Methyl dopa is moderate efficacy antihypertensive, and circulating levels of NA and renin tend to fall due to the reduction in the sympathetic tone, and inhibition of the postural reflexes is mild. Right, and methyl dopa was widely used in antihypertensive and especially in combination with the diuretic. However, it is infrequently used now, except to the treatment of the hypertension during pregnancy, wherein it has a long track record of safety both for mother as well as fetus. So treatment of hypertension is really needed because there are chances of target organ damage and complications like cerebrovascular disease, transient ischemic attack, stroke, encephalopathy, hypertensive heart disease, left ventricular hypertrophy, CHF, coronary artery disease, angina, MI, sudden cardiac death, arteriosclerosis, peripheral vascular disease, retinopathy, dissecting aneurysm of aorta, glomerulopathy, renal failure, and patients who have already suffered from TOD have greater risk of further organ damage and death at any level of the raised BP than those without TOD. Then there are risk factors like if the patient is more than 55-year-old and male patient is more than 55, and for female it is more than 65 years, because females and the dyslipidemia is less seen. And if the patient's family or ancestors is having a premature CV disease, smoking is also a risk factor, dyslipidemia is a risk factor, then diabetes mellitus is a risk factor, then obesity, microalbuminemia or GFR that is reduced 60 ml per minute. And compelling indication for the use of antihypertensive drugs are heart failure, high coronary artery disease, MI, stroke, diabetes, chronic renal disease. And then this we all have discussed in the morning wala session, and here we will be discussing about this thing was left, goal BP. So basically according to JNC 8, what should be the management of hypertension? So goal BP should be less than 140 systolic and 90 mm of Hg in all the patients, and 60 years or irrespective of the presence or absence of the diabetes and or chronic disease or chronic kidney disease. So basically goal BP जो more than or less than basically If the age is more than 60 degree, then your goal BP should be 150 to 90 mm without CKD and DM. And if the patient is less than 60 with CKD and DM, then your goal BP is 140 per 90 mm of Hg. Beta blockers are no longer considered as a first line drug due to the increased mortality. But first line drug include thiazides, ACE inhibitors, ARBs, calcium channel blockers. So first line antihypertensive drugs are thiazides, ACE inhibitors, ARBs and calcium channel blockers. Rest of the drugs are considered later line drugs, as blood pressure should be controlled by first line drugs alone or in combination. So ACE inhibitors and ARBs should not be given simultaneously to a person, and ACE inhibitors or ARBs are the first choice of the drug in the patient with CKD irrespective of ethnic background. For the patients with African descent without CKD, CCB or thiazide should be preferred. And now comes the CHF. So basically CHF के अंदर the aim of the treatment is to reduce the fluid and to increase the pumping. So if you want to decrease the fluid, then you have to give the diuretics, and you will be giving the loop diuretic. And pumping के लिए you have to increase the contractility, and thus you will be giving inotropic drugs. And let's discuss about the diuretics. So you'll be using the loop diuretic. It is preferred, and it is short acting, and it will be decreasing all the ions Na, K, H, Mg and calcium. And inotropics के अंदर we are having beta 1 agonist, that is dopamine, dobutamine, Na, isoprenaline, phosphodiesterase inhibitors, amiron and milneuron, inodilators. So phosphodiesterase inhibitors are inodilators. They are inotropic as well, plus they are vasodilators as well. So they can increase contractility, plus they will be dilating the blood vessels, and it is the drug of choice for right heart failure. So if anyone asks you that what is the drug of choice for the right heart failure, then you will be answering him amiron, milneuron or phosphodiesterase inhibitors. Then digitalis cardiac glycosides, because they increase the contractility of the heart. And treatment of the CHF, basically CHF जो होता है कार्डिक आउटपुट डिक्रीज हो जाती है, so that's why बॉडी के रिफ्लेक्सेस एक्टिव हो जाते हैं, सिंपैथेटिक एक्टिवेशन होता है, अल्फा 1 अगर स्टिमुलेट हुआ देन वोजो कंस्ट्रिक्शन होगा, वेन्स आर्टरीज कंस्ट्रिक्ट होगी, प्री लोड और आफ्टर लोड बढ़ेगा. बट हमें ये नहीं करना. अगर प्री लोड और आफ्टर लोड बढ़ेगा तो ये पेशेंट क्राइसिस में जा सकता है, राइट. बीटा 1 एक्टिवेशन हुआ तो कार्डिक आउटपुट बढ़ेगा, राइट. एंड बीटा 1 एक्टिवेशन की वजह से रेनिन सिक्रीट होगा, एंजियोटेंसिन विल बी कन्वर्टेड टू 1 एंड एंजियोटेंसिन 2, देन वेसोकंस्ट्रिक्शन हो सकता है, LVH हो सकता है, रीमॉडलिंग हो सकती है एंड डेथ हो सकती है, सोडियम एंड वाटर रिटेंशन होगा, और ये सब चीज़ें हमें कुछ नहीं करनी. सो फर्स्ट ऑफ ऑल वी विल बी डिक्रीजिंग द वर्कलोड. वर्कलोड हम कैसे कर सकते हैं? वेसोडाइलेटर से. फ्लूइड डिक्रीज हमें करना है, हमें फ्लूइड डिक्रीज हम कैसे कर सकते हैं? डायोरेटिक्स से. LVH डिक्रीज करना है, रीमॉडलिंग डिक्रीज करनी है, देन हम ARBs दे सकते हैं, हम एल्डोस्टेरॉन एंटागोनिस्ट दे सकते हैं एंड ऑल ऑफ दैट ड्रग्स. RAS इनहिबिटर्स तो सारी दे सकते हैं, बीटा ब्लॉकर्स भी दे सकते हैं. Then work decrease करना है, then vasodilators. We are having 3 types of the vasodilators. First is venodilator, arteriodilator, and both veno and arterial dilators. Venodilators consist of nitrates, arteriodilators consist of hydralazine. Veno and arterial dilators consist of a sodium nitroprusside, ACE inhibitors and ARBs. Then fluid को decrease करना है, then loop diuretics we have already discussed. Then LVH की अगर हमें decrease करना है, remodeling decrease करनी है, then we will be decreasing the mortality, and thus we will be giving beta blocker, ACE inhibitor, ARBs and aldosterone antagonists, right. So that was all for today, and we have completed all the things, CVS sum up session. So initially हमने स्टार्ट करा था रास से, हमने रास डिस्कस करा, हमने एंटी एंजाइनल ड्रग्स डिस्कस करा, हमने एंटी एरिथमिक ड्रग्स डिस्कस करा, हमने एंटी हाइपरटेंसिव ड्रग्स डिस्कस करा, हमने ट्रीटमेंट ऑफ CHF डिस्कस करा, एंड 10 अभी मैं आपको 8 PM पर दोबारा मिलूँगा प्लस कोर्स पर, एंड फॉर दैट अनअकैडमी की ऐप पर आप जाओ, शिव विरमानी सर्च करो और फार्मैक इजी सर्च करो, प्लस कोर्स दिखेगा, वहाँ एनरोल करो और आ जाओ. So I'll be looking forward to see you all there, and अभी 8 PM पर ही सेशन होने वाला है प्लस कोर्स वाला. I'll be waiting for you all. Thank you so much for coming. Thank you so much for attending this session, and take care guys. Yeah. So guys, take care, stay healthy, stay safe, stay positive, and we'll be meeting after 1 hour.